Less than 1 minute away. If you're out in the hall and want to come in, now's the time. All right, it's 1 o'clock, and we're going to convene Division Three's work session. This because of the calendar, not because we've got this perfect, but because we're out of time. This is effectively going to be the determinative meeting to form the Division Three recommendation. For those that aren't aware of the process, the subcommittee makes a recommendation on what to do with bills and money, HB2, HB1, and we make that recommendation to the full finance committee. And it isn't until the full finance committee hears it and votes before there's a finance position. Until then, there's a Division Three recommendation, which is a different thing. So if you think this is the end of the line, it's not. It's just another intermediate point to get us ready for full finance. Whatever full finance does then has to go to the House. April 10th is the big day for that. And whatever the House does goes to the Senate. So we are a long way from being finished. So the opportunity for the public to comment and interact is still viable after today. Now, based on what's before us and the number of people I've thought may want to testify, I've told security that we may be going to 6 p.m. I don't want to go to 6 p.m. I think we may be able to make our decisions a little bit quicker than that, because very little of this is brand new. Some of it is. But in order to get this started, I have to sort of do a set point on this. The challenge that this division has is that the governor spent more money than what Ways and Means says we have. And so the effect of that, not literally, but for the uses of conversation, we can only spend 75 cents on the dollar for what the governor spent. And that means a lot of tough decisions, and that means some out of the box thinking. So we've been trying to do that the best we could. Before we get going, I see a lot of people in the audience, and we have, I have an old rule of thumb about resource management. The first goal of resource management is to acquire resources. We've gotten the resources from Ways and Means. We've opened up an HB2 item so that organizations can donate up to $250,000 to the state. Is there anyone in the audience that thinks they want to donate $250,000? If you do, raise your hand. We'll let you go first. Or alternatively, if you see that the group that you advocate for no longer needs as much money, please step forward and tell us you don't need as much money. We need to be able to look at those things, because there are unlimited wants and there are limited resources. And so this is a very difficult task with making decisions in an environment of scarcity. So with that, We have people here. I know Representative McLean, you took off work, and I don't know if you need to get back to work. And I have Dr. Ballard here. I think on the first thing we're going to talk about, you might both want to come to the table. So please come forward. For the members and for the people who see this in background, we're gonna be jumping around just a little bit here at the beginning, and then it'll all smooth out. But a little bit here at the beginning, I want to make sure that folks who have made a point to travel here to testify at our request have a chance to go first. So in this long one that looks, in the Army we would call this the horse blanket. It's a big landscape. We're going to start with I want to start with Amendment 1176. And from my notes that I took just an hour and a half ago, I'm seeing a different sequence than what I was expecting. Where on the horse blanket is 1176?
Just about the fourth or fifth page in my.
There's only 3 pages that I see. Yeah. Yeah. The long page. Okay, so we'll use this long one instead, and it's item 28, and we're going to talk about Amendment 1176. This is a replication of a bill that got passed by the House yesterday, and that we've incorporated into. Oh, Jesus. That we've incorporated into HB2 as a potential House priority. So, Representative McLean, congratulations on having your bill passed yesterday. Would you remind us of the name of, or the number of the bill that basically did the membership-based business model?
Yes, thank you, Mr. Chair. Representative McLean from Manchester. And the bill number is HB 548FN.
Okay, and that passed on a roll call, didn't it? I don't recall the disposition.
Yeah, it was a roll call, yes.
Okay, about 200 to 160. Do you recall
Yeah, pretty much.
pardon me? Okay, so 200 to 157 or thereabouts. Okay, so with that, just go ahead and go through this on what the problem is you're trying to solve and why this seems to be a good solution.
Okay, the bill basically is an attempt to open up competition in the healthcare system. It does that by taking the direct care model that we incorporated into law for primary care 6 or 7 years ago, and it extends that model over to healthcare facilities. And so I think, we have a very good healthcare system from the perspective of, treatments and therapies, things of that nature. But the system itself is somewhat calcified. We're not seeing prices come down, and access is certainly not going up either. I mean, CMS put out a report where they think that in the next 5 to 7 years, we could lose 30% of the nation's critical access hospitals. Already here in New Hampshire, we've had 2 of them go bankrupt and had to be incorporated into Concord Hospital. So this this is not a cure-all, but what it's basically doing is it's just allowing the market a little bit of room to explore and see if there might be any innovations that might be able to come forward.
Can I restate that a little bit?
Sure.
I want to be sort of an objective devil's advocate.
Right.
Okay. So this is what I've taken away from the folks who weren't in favor of the bill, is that this bill hasn't been tried in New Hampshire. It's a little bit of a free market theory without it being proven. That there's concern that this model will cause those with money to go to the newer facility, which would take the higher payers in the payer mix of the existing facilities out of their system and would exacerbate their financial circumstances.
Yeah, and I think you said it rather well. The fear of those who oppose the bill is they're really concerned about the health of the state's critical access hospitals. They think that this could essentially be a nuclear bomb, as it were, because it would basically come in and it would be, by freeing people up of all the burden of having to accept Medicare and Medicaid, it's going to do some cherry picking. More people are maybe going to want to explore that model, and it's going to steal away from the nation's critical access hospitals. So I think you put it, very well. There is at the back end of the bill, because this bill has come forth a couple of times and there's not a lot of data around this. So the bill does create a study to kind of look at the impact of the direct pay models. The only thing, though, I would say to address some of those concerns is one of the flagship facilities that you hear about whenever this bill comes forward is the Surgical Center of Oklahoma. And you hear about that a lot because Oklahoma has adopted this direct pay model for facilities. And the only thing I would say to folks that are really afraid is that the Surgical Center of Oklahoma opened 28 years ago. And in all that time, there is no second or third or fourth or fifth surgery center of Oklahoma. There's still just one.
Right.
And so I don't think that there is a massive market for this, but it is an opportunity to explore.
Right.
And in Oklahoma, you still have 150 hospitals, more than 40 of which are critical access hospitals.
Right.
And so I think that as I said, CMS has already identified that the model itself is what is dragging down the critical access hospitals. Within 5 to 7 years, we could see up to 30%, they think, go, which is why Congress.
So I'm missing the connection. How does the introduction of your model make the critical care access hospitals more viable? I don't see that connection.
I don't think it makes the critical access hospitals more viable. I'm just saying that the threat that some see to critical access hospitals by this bill is overstated. So I'm just saying that if this was going to wipe out critical access hospitals, it would have done so in Oklahoma, which has had this model for a very long time, but you haven't seen a wide penetration. Right. So I think that there's always risk, but looking at where it has been applied, the risk is a bit overstated. That's all I'm saying.
So the Oklahoma example, the other thing that's sort of different about it than what we've got going on is that it was built in the northwest corner of Oklahoma City, out where the cow patches were, and there was no construction anywhere near there. And then the interstates got built around it. And so it was sort of like the first leading institution within that region. And so New Hampshire, we don't have sort of that green zone. These would be more directly competitive from the outset. Dr. Ballard, is this one of the bills you wanted to testify on? Because
No, sir.
there were two McLean bills I think you wanted to testify on one of them.
No, sir, not at this time.
Okay. All right. So, are there members? Okay. Stringham, Representative Stringham?
Yeah, I have a couple of concerns. First of all, critical access hospitals make tax payments to the state in the form of the MET. Is that correct? And would these facilities pay them? So if they remove procedures, are we impacting financially the whole state funding formula for hospitals?
I don't know how that tax works, to be honest with you.
Yeah, so that's a percentage that's paid. So, I mean, I think for me, that's a major concern. Another concern I have is not just cherry picking patients, but also cherry picking the most profitable services. And, you know, having things that, you know, it happened about 20 years ago. Interventional cardiologists started forming specialty hospitals, they called them. And they started moving patients in. The DRG payment formula was extremely favorable to those procedures. And after about 5 or 6 years of essentially draining some of the highest gross margin procedures out of the hospitals into the specialty hospitals, Medicare changed the DRG inpatient formula to better align the costs with what was actually being delivered, and those incentives kind of went away. And you know, even if it's quite a ways away, I could, you know, a relatively small amount of business shifting away from a critical access hospital could accelerate its non-viability. So, is that
Are
is
there
that
other
helpful?
Are there other member questions? Are you done?
Yes.
Okay. I don't want to interrupt you. Representative Priest.
Thank you, Mr. Chairman. Good afternoon, fellow
afternoon.
representative from Manchester. It's good to have you here. Has this been offered, or this model been offered and accepted in other states besides Oklahoma?
No, Oklahoma is pretty much it's not a broadly accepted model. So this would put us, you know, out on the leading edge. Absolutely.
Okay, thank you.
Other member questions? Is there anyone? I don't know whether to call you all the audience or the gallery. So, would you like to come up, Mr. Ross? Okay. Okay. I'm gonna bump you, Dr. Ballard, because I called you up prematurely.
Thank you. Good afternoon. My name is David Ross, for the record, and I am the administrator of Hillsborough County Nursing Home, and I am here on behalf of the New Hampshire Association of Counties. We do take a position opposing House Bill 548 FN due to the removal of the moratorium on nursing home beds. There's discussion this afternoon has been about critical access hospitals, but this specifically also removes a moratorium on nursing home beds, skilled nursing beds, inpatient rehabilitation beds, for facilities that would be self-pay. The state has had a moratorium on nursing home beds for several years, and we did that with really the intent to be able to control spending in long-term care and to be able to push and incentivize growth in community-based care. Expanding removing the moratorium for this class of patients will remove that moratorium and create precedent to be able to remove the moratorium altogether going forward, which causes us great concern. But it's also going to put a lot of pressure on all facilities and ultimately the state and the counties regarding Medicaid rates. Creating a separate class of facilities that are just for self-pay will undoubtedly remove private pay patients from current facilities that all facilities do rely on to be able to help balance operational revenue and to help cover expenses that Medicaid does not cover. Pulling them from there is going to put pressure on facilities to have increased Medicaid rates because the percentage of Medicaid patients in them across the spectrum is going to increase. Right. That's going to put pressure on us as counties to be able to afford that and across the board, across the state. we would request that the moratorium on beds referencing nursing homes, intermediate care facilities, skilled nursing facilities, and rehabilitation facilities be removed from the language of this bill.
So you haven't had a chance maybe to take a look at 1176?
I have not.
I don't know if anyone in the audience has looked at it, but if you have specific lines where you want to recommend a strike through, could we do it that way? Because
Sure.
we're just trying to figure out if we should include this language or not.
Thank you very much.
Oh, sorry.
This one- yeah, this is not the same one here. Yeah.
So just while he looks at that,
Yeah.
Mr. Chair, to give him a chance to get his bearings.
Right.
We did hear testimony in the policy committee with respect to, the concern about nursing homes. The Catholic Church also testified that they had some concerns in that regard. So, and I felt that those concerns were reasonable. I do think that in the future, we do have to, with an aging population, find a way to get around this moratorium, but I don't know that this bill was the right vehicle to do that. So the amended language does address that, and this bill does not apply to nursing homes or skilled nursing facilities. So it's completely carved out of the bill. So
Do you agree with that, Mr. Ross?
His concern.
I'm trying to digest the language, to be honest with you, Representative, because it does appear that it's not quite adequate in carving it out, and I just want to make sure my understanding of the language is clear. But I think it's necessary to make sure that there is a carve out here. So
So this is there anyone else that wants to speak on this issue? Is that you, Mr. Bradley? I can't see very well. Yeah, come on up. You can sit here at the edge. You guys are fine where you are.
Okay.
Thank you, Mr. Chairman and members of the committee. For the record, my name is Ben Bradley. I'm the Vice President of State Government Relations for the New Hampshire Hospital Association. We did share some concerns, and they are included in the record on the consideration for this bill, HB 548. I won't repeat what's already been said, but I do also want to point out a few things. One is that this type of business model appears to set up a regulatory framework that treats facilities differently based on whether a patient direct pays. It also appears that these new facilities may not have to follow the CMS conditions of participation, which include important patient safety and quality requirements. The bill also sets up a separate patient bill of rights. So New Hampshire has an existing patient bill of rights that hospitals and other facilities have to follow. This bill sets up, as I mentioned, a separate bill of rights, and I'd like to point out a few provisions in the original bill that I'm sure are included in what you have in front of you with the amendment.
May I just stop you there?
Sure.
Because I need to keep the whole thing moving, and
Yep.
I think I get the gist of what you're saying. And Representative McLean, this is what I'm thinking. Your bill passed the House. It's off to the Senate. This HB2 basically is the same thing as your bill. There seems to be enough good input to suggest that what I have in HB2 might benefit from further conversation and amendment. That's beyond the scope of what I can do here with the time. So I think I'm predisposed to removing this item from HB2, knowing that it's still in the Senate, and these conversations right here seem to me to be the key to increasing the quality of the debate in the Senate and maybe get an even better bill out of the Senate for us to reconsider. So because this is your bill, I want to tell you that directly. What do you, how do you respond to that? Do you understand what I'm trying to do?
Yeah, I mean, I do understand, Mr. Chair. I would just, though, just make a couple of comments. I think that these concerns are going to carry all the way through to the Senate. Unfortunately, I didn't have an opportunity to write down all of Mr. Bradley's comments, but with respect to the CMS rules, all the rules for health facilities licensure would continue to apply. The only exemption is for the all payer component. We did put out remove the nursing homes. And so I just think that whether it goes through in the budget or whether it goes through as a standalone bill, I think that the concerns raised will continue to be raised.
Right.
Because at the end of the day, there is risk with this bill. And I don't want to sugarcoat that there is risk.
Right.
But I do believe that the risk is acceptable risk
Right.
because we just do not, I think, have a sustainable model. So, I respect your decision.
I'll agree with your conclusion. The current model's not sustainable. We have to figure out how to do things differently. And the current model, I think, is heavily regulated and would benefit from some free market principles. But I just don't know if this is the right bill at the right time in the right forum. And rather than have this bill, HB2, try to adapt to some of these issues while your bill 548 is going through the Senate, I think I'd rather, because there's still some complexity, I'd rather let the policy committees of the Senate focus on HB 548, because the HB2 process is not as deliberative as a standard policy, and I'm just not feeling that this is cooked enough. That's my perception.
Right.
So I've done a lot of speaking. Are there any other comments from the membership on this? Representative Wallner.
Oh, I'm sorry, I had to go out to get a little bit of water. Coughing. I think that what you lay out here and let it go as a standalone bill over to the Senate makes a lot of sense. We don't have the time
Right.
to really delve
Well, we
into
could stay
this.
till 7.
I think it would probably take long. It's
No,
seven.
I'm
seven
jo-
on
that was
what
a joke.
date?
That was a joke.
Yeah, thank you.
Okay. Representative Stringham.
Yeah, I agree as well, and I just want to express a little concern. This is a bill with a financial note, and it went through as a one committee bill.
All right. Is there a motion then on whether or not we should accept 1176 into HB2? Representative Tulerski,
I'll make a motion to not accept it or remove it from the agenda.
is there a second? All right. Let's go ahead and do a roll call. And your mic's not on, and it's not pointed at you.
It's not pointed either. Mooney,
Yes.
Daniels,
Yes.
Seaworth,
Yes.
Nalavenko, yes. What? Tulerski,
Yes.
Wallner,
Yes.
Stringham,
Yes.
Priest,
Yes.
Edwards.
Yes. 9-0
9-0.
to withdraw. Okay, so I didn't help you today, but if there's anything I can do to help this process in the Senate, let me know.
Thank you very much. I appreciate it.
All right, now, do we have one of your other bills before us, or did,
Mooney.
Sorry, the licensing of substance use disorder. Was that your bill?
That was my bill.
Yeah, 751.
Yes.
I tried that and unfortunately it was voted down along party lines on Tuesday.
so it should be one of the gray areas we voted 5-4? Do you know which one we're referring to, Mr. Ripple?
House Bill 751. Let's see.
Yes, it was Amendment 1253H, and it's line number 41 on your list from today.
Page 2, line 41.
That's
Okay.
correct. So it was not accepted on the 25th.
So we would not accepted. All right. All right, Representative McLean, thank you for coming.
Thank you, Mr. Chair. Thank you, members of the committee.
All right. Dr. Ballard. Okay, I would like to start talking first about the standing order bill,
Okay.
and I need to find the new version of it
The
because
new amendment number is 1386H.
1380. Item 44.
It's line 34 on your list from today.
34. 34, and okay, on hold C 1356. Okay, so 1330 on line 34 is not relevant because we're going to go look at 1386 instead, I think. And where's 1386? It's
So-
44. Somebody
Sorry,
already said that like 5 times.
Sorry. So line 34 references the original amendments,
Yeah.
and it says it's on hold pending 1386. So
Right.
my mistake. It is actually on line 44. However, you will notice, as I just did, that the line numbers on the second page of this sheet are all over the place. So the new amendment 1386.
I don't see any reason why we should follow standard math principle. This is a budget process. Okay,
Yes.
so find number 44 somehow, and we have amendment HB2 is 1386, and you saw an earlier version that only dealt with Medicaid patients, and in the discussion, we said we would like to do more with it. And since then, Dr. Ballard and Mr. Lippman have talked with Commissioner Ballancourt in the insurance department. So from that, what can you tell us?
Good morning, Mr. Chairman, committee members. For the record, my name is Jonathan Ballard. I work as the Chief Medical Officer at the New Hampshire Department of Health and Human Services. This original language came from part of the language from Senate Bill 119 FN from Senator Gray. And at your request, we went back and looked at how to apply the standing order designed to save money in the Medicaid program to be allowable for use for non-Medicaid beneficiaries. So typically, in order to process a over-the-counter medication or any other type of product through the prescription system at a pharmacy, there needs to be either a prescription or a standing order, which has a provider's ID number to attach it to in the processing system at a pharmacy. So at your request, the language starting at line 8 going through line 12 is new. And this is stating to allow any insurer or any non-Medicaid beneficiary to use the standing orders that will be created to be applied to their situation to receive potentially a lower cost medically equivalent product. It does not require, though, that the individual insurer or other payer is mandated to cover that product unless it's included in their terms of coverage. And that was what was provided to us from the Department of Insurance.
So in a way, it's a little bit like enabling legislation. We
Exactly.
can take a standing order, it'll apply for Medicaid. If you're not Medicaid, it'll be dependent upon your insurance company's policies on whether or not they'll honor it.
That's correct, sir.
Okay, so that sounds like maximum flexibility without coercing or controlling the private market.
Yes.
Okay, so I appreciate you looking at that. And you said it was SB 319, the gray bill. Did you say 319?
SB 119 FN.
Okay.
This is a second half of that bill.
Right. Okay, now, There were about 5 items, Mr. Lippman, that we began the whole budget year with, that if Medicaid made changes, you forecast that we might be able to save some Medicaid money. Was this one of them?
Yes, this was, the first part of this was definitely that.
So because we're keeping track of differences between the governor's budget and what we're proposing, those savings are already built into the governor's budget.
Correct.
Okay, and because the thing we're adding here is about the commercial market, that has nothing to do with state funding. So I think this is basically budget neutral, but just a better thing for New Hampshire, which,
I think that, we're not speaking for the insurance department, but they
Right.
were comfortable with this. We dealt with both their counsel and with the commissioner, to my understanding.
Yes, it was not predicted to save the Medicaid program or DHHS any additional funds. This
Okay.
change.
Are members, Representative Tversky?
Thanks for taking my question. I'm just trying to understand exactly what this means. And I'm wondering how this could affect an individual consumer who is going to get care, if they would have flexibility, if they didn't prefer the standing order and wanted to do something different.
Thank you, Representative Solarski. This gives them the flexibility to choose, essentially. So in the Medicaid program, we can cover a medically equivalent over-the-counter product, but it has to be processed through the claims system to bill back to the Medicaid program. We cannot reimburse a beneficiary for a medication. We can't pay them. And so what this would allow, for an example, just give a quick example. So there are allergy medications. They go over the counter when a new medication is released to the market that's more expensive, but they're medically equivalent. There's no head-to-head studies that show that the new medication, that's the prescription medication, is better than the one they just kicked to the over-the-counter. So this gives the Medicaid program now flexibility to cover a medically equivalent but cheaper option that would be a over-the-counter product and make the more expensive medically equivalent one the non-preferred product.
Okay, so I'm following that. And I understand this, having experienced this, a prescription that my family used for a while, then they had an over-the-counter product that was much more expensive than what my insurer would pay for my original product. So I guess I'm just trying to understand how this applies, though, to that, the private insurance.
For the private market, then they could
It would
follow
be the
suit.
same thing?
They could choose to
Okay.
follow suit the same way, and I think
They
it would
could
be in their
choose,
interest.
okay, but
because
they don't have to.
They don't
Okay,
have to.
I got
No
you.
requirements.
Thank you.
Any other member questions? Is there anyone in the gallery who wanted to testify on this? All right. So I think the only issue here is making sure that Senator Gray knows that if we keep this in HB2, this is distinct from the portion he has in SB 119. I think I'm ready to hear a motion on whether or not we should accept 1386 into HB2. I see a motion. Is there a second? And a second? Okay, I think we can do a show of hands on this. If you're in favor, you'll raise your hand. If you're opposed, you'll raise your hand. So that's 9-0. So thank you very much, Dr. Ballard. There was a second bill you wanted to talk about.
The second one is 1402H.
Okay, 1402H,
it's coming
and
to
this
you.
is the Medicaid cost sharing for outpatient procedures.
Yes, sir.
And that should be in the packet of HB2s. I think that's the one immediately, or no, it's not.
It's coming out to you now.
1402. Give us a second just to make sure we're looking at 1402. While
About the fourth page.
the amendment number is 1402, isn't it? It's in the front.
Fourth page.
Fourth page. Okay, I see it. Okay, assuming I've got to be the slowest, I'll let you start talking to this.
Sure, I'll take this one. The changes here are to make it fit within CMS regulations in terms of what would be allowable for the sharing of costs, because there are limitations as have come out earlier on premiums that weren't addressed in the original version. It also, in terms of the mileage requirement and patient choice, those were some of the issues, technical issues that we saw in the original draft. So I think you tasked us to come back with something that could achieve the intent of what we're looking to do. And I think that this does, is that basically it would both provide an incentive to the managed care organizations and to the patients for those clinically appropriate situations to have a chance to have a choice if they so chose, and to have an incentive to pick a lower cost setting. And so this is something actually that in 2018, when SB 313, there was a concept that was included in that bill that didn't end up really coming into play. I think based on experience, I think this is something that could be implemented fairly readily and be of value to the individual, as well as encouraging the MCO to work to find these opportunities and to make those opportunities aware to the patient. And I'll let Dr. Ballard answer any clinical questions you have on the types of procedures.
So you're comfortable, you've seen this language. This
Yes.
is the language you contributed to, and you think this is the right language?
Yes, we do.
Okay. And to what extent have you validated with the MCOs that this is a concept that they're interested in working with?
Given the time frame that we had to do, I had to turn it around in less than
Okay.
12 hours. I have not had a chance to validate it with
No,
them, but I
the
think
prior concept.
the prior concept,
incentive
we work with,
concept,
yeah, sorry.
Mr.
Go ahead.
Chairman, the incentive concept is a component of the current managed care
Right.
contracts.
Right.
And it is allowable under CMS to provide incentives to patients to achieve a better health outcome or a lower cost setting.
Yeah.
A classic example that's in most states is that if a woman attends a pregnant woman attends prenatal visits, a certain number of them,
Right.
that they were given a car seat upon delivery of the infant. And
Right.
so that's the incentive type program. There is a maximum amount that CMS allows for, but it is a program that's already existing. But we could leverage that to encourage free market decisions to choose the lower cost setting. There are many ambulatory surgical situations
Yeah.
where the costs vary widely based on where you get it.
Right.
If you're at a hospital-based or in a hospital receiving a procedure versus a non-hospital based ambulatory surgery center, the costs vary greatly. And this would give that member some incentive to choose a lower cost setting with the MCO's input and coordination.
Is there anyone here that wants to speak for the MCOs to see if we're not speaking out of turn, that we actually do understand the MCO position on this? Anyone want to speak? I don't see anyone wanting to speak. Okay. All right. So, so thank you. Do you have questions?
Yes, I do.
Let's do Representative Priest and
Yes,
then
thank you,
string 'em.
Mr. Chairman, and thank you for being here. Do you have examples of where this has gone into effect and the cost savings that particular state has received and the patients and, Thank you.
Representative Priest, great question. So the best example is actually in the private market. There are insurers that work with their beneficiaries to choose lower cost settings, particularly in imaging. The example would be an MRI. There are MRI locations at hospitals that are very expensive. It might be a $3,000 MRI versus a $600 MRI at another location. And there are various programs through private insurers that this is simply trying to mimic.
Now, was this one of the 5 elements that you put into the governor's budget? If we do this, does this change any of the budget assumptions?
This was not one of the original ones that we came up with. I do think that I did not have enough time to develop an estimate of what the savings would be, but I think that it's certainly in the time period to build out the program, educate the membership.
Right.
It's a small dollar, I think, in this biennium.
So I'd like to make a request of you then. If we put this into HB2, would you continue to think through the implications on our Medicaid spend and share that with the Senate in case that there's something there that they may want to identify?
Absolutely, and that'll give me a chance to work with the MCOs in terms of understanding what they see as well. So would
Right.
appreciate being able to do that.
Representative Stringham?
Yeah, the other question I just had, it says within 30 days of the effective date of this paragraph. What is the effective date of this paragraph?
July 1 is the assumption on everything when it's in HB2.
Thank you.
Good question. I've heard that question asked before. All right. So are there any other comments or remarks from the gallery or from the members on this? If not, then I think we're ready for a motion.
I move approval of
I move,
1402H.
oh, somebody,
He started to move it.
oh, okay, sorry.
So are you okay to second? Okay, second. So I think we could do a show of hands for line 49, amendment 1402. If you're in favor, you'll raise your hand. If you're opposed, you'll raise your hand. So I see 9-0. So thank you.
Thank you.
Do you have anything else while you're here, or are you
do not.
done, Dr. Ballard?
I'm done, sir.
All right, thank you. So, Mr. Lippman, one of the big things we're going to do, and I see people here, so I think we'll jump into the big ugly like right away, and that is now Amendment 1492. 1492 represents a revision from what people were discussing last week. Where is 1492 on the sheet?
I'm not sure our amendment numbers go that high. What's the subject matter of the amendment?
The subject matter is basically having the transition of long-term care into the managed care organizations.
Okay, that's 1429, and it's the second amendment in your packet.
1429. Oh, I transposed the numbers. Okay, and so this revised 1285, which is what got discussed last week. Now, so because, or I guess that was just Tuesday, geez. Yeah, the first 54, right? Yeah, oh, there are two of them, that's so cool. Okay, so Mr. Ripple, I don't see the amended analysis on this. Did it get dropped off?
I think it probably did as we were putting the packet together, yes.
Oh, okay. Would you do us a favor and start out by reading the amended analysis?
Sure, let me just pull that up quickly.
Right, I want to release that.
Sorry, while
Sure.
he's doing
No,
that.
while he's getting ready, go
Yeah,
ahead.
I'm looking at the line, the first 54 line that we're looking at, and it says revising 1285.
Yeah,
So is 1285 an original amendment we looked at?
yeah, we
Okay.
talked about it Tuesday or Monday, or we talked about it earlier this week. And it was basically the issue of transitioning long-term care from the DHHS responsibility to more of an MCO
Yep.
responsibility and kind of a shared responsibility
I
environment.
just was looking for my notes from 1285.
Yeah, and this caused a
Thank
great
you.
deal of interest rather rapidly.
Sure it did.
So much so that I was subject of my first ad placed in the Union Leader opposing this. So I found that fascinating that in the process of conversation that people would go to their corners so quickly. But so are you ready for the amended analysis?
Yes, the amended analysis on this amendment 1429 reads, this amendment directs the Department of Health and Human Services to include long-term care in Medicaid managed care by January 1st, 2028, and establishes a commission to assess the viability of Medicaid long-term supports and services transitioning to managed care.
Okay, and you read the part about the commission. Yeah, okay. So that's the major difference is is the portion of this that was the law. This bill would postpone implementation until January 1 of 28. And more immediately, a commission would be established that would have as its charter the obligation to determine the viability of the law, and if there are recommendations to changing the law, that they would make those proposals. Started in September of this year, so that it coincides with the legislature's OLS drop dates. The reason for putting this into law is because we've looked at this in 2018, and it just seems to me like we still are not saving everything that we could save. We're not delivering the kind of care we need to deliver for getting people into CFI. That there seems to be some systemic things that are getting in the way of having the current status quo really performing in an excellent way. And so by proposing this alternative view and putting a bunch of smart people together, to include leaders of the 3 MCOs, leaders of the county, with some legislators involved, that we could have a conversation to determine if there are ways to improve the current system or by improving this particular law. I think we need to figure out a collegial way to have that kind of conversation. And this HB2 is intended to do that. No options are taken off the table. This is just a bill to begin the process of a serious conversation with an ongoing legislative effort to tweak and refine to see if there's a smarter way for the state to do long-term supports. So we could start in any number of places. How many of you have actually had a chance to look at 1429? I see Mr. Ross, you've read it. Do you want to go to the microphone, and then Mr. Thomas, is there anyone from the MCOs that have read this and here to want to talk? Kennedy, right? Mr. Kennedy? Could come on up, and in the spirit of collegiality, sit right there next to Mr. Ross. Introduce each other. All right. So for the people who don't see where this is going, I think Mr. Ross and Mr. Kennedy have different points of view, and both are valid, and I want to hear them specifically as it relates to whether or not 1429 ought to be included in HB2. So Mr. Ross, you moved first, so tell us what you think.
Thank you very much. I very much appreciate the establishment of the commission, and I think that this amendment really brings together the right people to be able to look at managed care, or the potential transition of managed care for our LTSS. My concern with the amendment is everything before the establishment of the commission, because it appears that we're putting the cart before the horse. And I would suggest that the commission, with the parties that are proposed here, would be very focused and driven to be able to look aggressively at this issue, to be able to make the appropriate legislative actions or recommendations to proceed without already having the law in place, that we're making this transition before we've actually done all of those appropriate assessments and evaluations.
So to play honest devil's advocate here, I think we've tried something similar in past years. I don't know how 2018 got resolved, but the reason that I've included the law in here is to give everyone something to focus on, a deadline, an idea, words on paper, rather than going into this sort of ambiguous grope. There's something actionable here that you can determine viability and improvements in a collegial environment. That's the logic of that. And I think you're right, but do you see the point I'm making?
I saw that point clearly evident when I read the amendment, that I think that you were trying to set a finish line that the commission had to work towards, and I think that that is evident. My suggestion is that the membership that you have proposed on this commission would be driven with that same goal in mind, without having the legislation already
So
in
I can
place.
take the round out of the gun and
Take the round out of the gun.
set the gun down.
Agreed, and say, let's have a collegial discussion, and to really engage actively about how do we right this ship, and collectively determine how do we support long-term services and supports here in
Right.
New Hampshire
Right.
in an appropriate way.
Thank you so much. And thank you for taking a discussion. I mean, that's what this is, right? This isn't just testimony, it's interaction. So, Mr. Kennedy, what would you like to say?
Mr. Chairman, so first of all, Chris Kennedy with Centene and New Hampshire Healthy Families. We are one of the managed care organizations working currently with the department on the Medicaid population. You're right. I do have a slightly different perspective on it, and I think you won't be surprised to know that I do agree with your perspective on it. I think that it's important not to have a gun, but a clock on the conversation. Just for historical benefit, I will remind folks that long-term services and supports were initially envisioned to be part of the state's managed care program at inception back in 2013, 12 years ago. The chairman is right that in 2018 there was another discussion among this body and the rest of the House in terms of the public policy of reincorporating long-term services and supports, particularly for nursing and CFI, into managed care. The MCOs were prepared to do it then. We're prepared to do it now, of course, in partnership and consultation with the Department of Health and Human Services. I think, what's that, 2.5 years is the runway that the time frame outlined in the bill gives the parties to sit at the table and figure out a way to do that. I think that's a reasonable period of time. And I think with the department, with the other stakeholders, including CFI providers, including, of course, the nursing homes, both county and private, and the MCOs, I have a high degree of confidence that we can figure out a way to do this. And again,
Thank you. Now, generically, I know that the department doesn't like to take positions on policy. They're saying that the policy is the purview of the legislature. But I'm kind of curious if this may be a little bit different in the sense that if this approach were to become law, the department would have a different set of responsibilities in terms of doing the medical evaluations on the patients, and would also have a role. I think there's a role on the commission for the department as well. Is there anyone in the department? I think you're already there, Ms. St. Cyr. Do you want to speak to your thoughts on this? And you're already forgiven if you stray into saying what you really think, as opposed to saying you don't take a position on policy.
Actually, I'm here for a small issue, and I'll actually let Henry speak to
Okay.
the department's thoughts on this issue. The one thing I just wanted to point out from a legal perspective, Melissa St. Cyr, sorry, Chief Legal Officer for DHHS. From a legal perspective, just have a little concern about the membership of the committee. Having the MCOs may be a conflict of interest under our state law, so we may want to potentially have the Department of Justice weigh in as to whether or not creates a conflict or not. So that I just wanted to point that out for the committee.
If I could add to what you're saying, I think with respect to the decisions on how they would get paid in particular,
Correct. Yeah.
that part of the charge.
So specifically where it says mileage reimbursement is authorized, is that the line you're referring
No,
to?
in terms of the methodology that they would be paid under, because,
Oh,
and there could be other parties that have a conflict in terms of, financial interest, but I think the one in terms of whether you go forward or not and how it is paid for, I think is,
Can you stick your finger on the line, page and line?
it's in,
Page 2.
it's in, starting on page 3. Well, I'm seeing it the first place in terms of the decision-making, that paragraph beginning with Roman 3,
What line number?
starting on 28 through 35.
28 through 35.
That in terms of on line 32, it talks about the department's capitation plan for such services. I don't think it would be appropriate for them to both be a bidder and determining.
So is there a simple strike through to remove that from the comma that says including the department's capitation plan for such services? What if we just remove that?
I think that there may be a concern just with the fact that they'd be voting on, you'd want the commission to be able to vote on and have the members vote on how to move forward with certain things. And when one of those certain things is payment and how you're going to involve the potential bidders for that, it may be a conflict of interest. So having them provide information and having them at the table is really important, but having them a voting kind of member of the commission is where the conflict may arise.
I think their input is valuable to the process in terms of their experience in other states and bringing that forward. I think, though, when you come to something that they're going to actually be a part of, that's where I think the issue comes up.
Legally, I bet you're right. But also, someone could make the argument that the state and the counties also have vested interests.
I did opening up
And
say-
conflicts of interests, potentially.
in terms of where the benefit lies, I think one of the issues that is vexing in working through this issue is I don't see in the charges, what happens to the county's financial responsibilities under this if there's a transition. I think that's, I'm not speaking for the counties, but I think that, where they pick up 90% of the cost currently, that they would have concerns based on that. And then was raised in 18 were two issues around how this would affect the two payment streams that they get in addition to the daily rate. They pay a tax called NFQA, Nursing Facility Quality Assessment Tax, somewhat similar to the MET that leads to their Medicaid quality incentive payment, and also for counties, the pro share payment. Those, I think, are things that should be added to the charge if you're going to look at this, because if those would be, I think, automatics for counties to say, this is really scary to us financially.
See, I was hoping this process would bring that forward as well, that's part of the viability test. If we're going to bankrupt the county somehow, we need to know that's a major factor. So I would assume the commission would come across those things and be able to present it. That was the working theory on this commission that hasn't formed yet.
And I just,
There's a hand down here.
Yeah, thank you, sir. My name's Ray Bauer. I'm from Stratford County.
Yes, sir. I've heard your name. Your
I don't know if
reputation
that's-
precedes you.
I don't know if that's good or not,
It's
Representative
good.
Edwards, but thank
It's
you.
good.
Just quickly, we're talking about a $60 million impact on the counties in terms of loss of
1-6
revenue.
or 6-0?
6-0.
Okay.
Collectively from the counties. Just in Stratford County alone, where I'm from, it's 20%. It'd be a 20% tax increase.
So that 60, I just want to understand what you're saying. I'm not challenging it. I just
Yes,
want to
sir.
understand it. So currently, because of your nursing home occupancies, there's $60 million that you all are receiving from Medicaid, I think, is what you're saying. And so this would change that to some extent, but presumably you still have the beds, and whatever the emerging model would be, you'd still be filling some number of beds. So it wouldn't be a $60 million hit, but there would be some potential shifting within that 60 million.
What he's referring to is actually the loss in pro share and MQIP funding, and not for the direct service payments that we're receiving for Medicaid patients. So we get the enhanced payments through ProShare and through the NFQA and the MQIP payment. That results in additional payments to the counties of $60 million that would not be available to us through the transition to a managed care system. And all facilities across the state would also realize the impact of the NFQA and MQIP impact. However, I do agree with you that that's all stuff that should be discussed at the commission.
Right.
And I think all that stuff would come out through the commission, which again is why I think removing the first part of the amendment that implements the legislation without first having the commission meet and review all factors, I think would be helpful.
Okay, so I hear you. And if I had a few days, what I think I would want to do is starting on page 3, everything above line 5, I'd consider striking and just turning this into a commission only. But I'm hearing enough to where, that there could be some conflicts down below as well, that the commission isn't built properly here either, that we'd need time to address that.
If I could, I think there's one other issue you may want to consider.
I don't.
Okay.
And the reason I'm managing a clock. Okay. So what I think we're at, unless you're going to disagree with this, is, I think we ran up the hill as far as we could in this initiative, and we couldn't get to the top. And that this commission could be something that we could talk to the Senate about adding into their HB2 with the proper language, which means people still need to stay involved in the process so that we can give the Senate something that's more mature. But I don't think we're prepared to recommend this to the full House, which is our decisions today. It's not cooked enough. And I'll take responsibility for that because I'm the one that's been trying to make this happen. So I think we're ready for a motion.
Okay, I would make a motion to withdraw Amendment 1429H, which is the first numbered 54 on your program.
Is there a second?
I second it.
Well, Representative Wallner, too.
Representative Wallner, did you have discussion? Did you want to say something? No. Oh, okay. All right. Yeah, Representative Seaworth.
Hopefully this is very quick. What I'm confused about is this amendment deferred any financial impact beyond the current budget session. Does simply withdrawing everything that we had so far change our calculations?
No,
Okay,
this
thank you.
had no financial impact in the coming budget, but we really have to figure out how to improve systems performance, because we estimated CFI numbers in a waiver. We're way short of that. There are smarter people than me that know why that is, but I think we can't be satisfied with the status quo, and this was an attempt to shake up the status quo. So next Division 3 should maybe have a solution. Yes, sir.
If I may, Commissioner, that we are also including this on the agenda for our County State Finance Commission as well. Just so you know, we agree with your assessment that this does need to be addressed.
Right. And Mr. Kennedy, I'm sorry. I think the MCOs were interested in having something like this get through. I just haven't cooked it enough to do the right thing.
Appreciate the opportunity for the dialogue, Mr. Chairman.
All right. And stay engaged. Please stay engaged. Okay. All right. Thank you. Pardon me? Oh, we didn't? Oh, I'm so sorry. So we have a motion on the table. Show of hands. If you're in favor of the motion to withdraw 1429, raise your hand. If you're opposed, 9-0. All right. Thank you for the reminder. Okay, so I'm not seeing anyone in the audience with a a pressing issue. If I'm missing an action for which you're waiting and you need to get out of here, please raise your hand and make me aware. Because otherwise, I'm just going to start going through this list on a more ordinary, routine basis. Representative Tulerski.
I had a conversation with someone who made a special trip up here to speak
On which item? Do you know?
to the family planning number
Okay.
from last week.
Yes,
Or
ma'am.
Tuesday. HB1 line 17. Or sorry, it's on the HB1 document.
Okay, and we have a new HB1 document as well, Mr. Ripple. Did you give us one of those
It's
too?
the landscape version.
Yes,
You're right.
landscape labeled Division 3 status of budget actions related to House Bills 1 and 2, and it has today's date and timestamp on it.
Okay, the date timestamps in the upper left-hand corner, the 28th. Is
Yes.
that it?
Yes.
At like 1 p.m. or something?
Correct.
Okay. All right. And I'm sorry, tell me the line item again, Representative Tulerski.
Line 17.
Line 17. So we voted on this, and we've already determined to delete this family planning account on a 5-4 basis, as I recall. What you'd like to do is have us reconsider that?
I know that there's two people who made a special trip today. I believe they had reached out to you
Do you have a
previously.
motion to reconsider this?
I have a motion to reconsider it.
Is there a second? All right, raise your hand if you're in favor of reconsideration of line 17. Okay, if you're opposed, raise your hand. I didn't count 9 hands altogether, but I think we got over the 50% mark. So if you're here to talk about the family planning deletion, please step forward and take a seat and introduce yourself.
Mr. Chairman?
Yeah.
Just for, you know how I think. I feel a lot more comfortable if you made that motion to reconsider, having voted on the prevailing side. I don't know what the rules are for a committee, but.
Yeah, we're not
since
even
it's
a real committee,
All
though.
right. Fair enough.
We're pretty flexible. It's all work session. Do you have a comment?
I do. I just have a question, comment. What if we had the individuals who traveled testify, and then if we feel a need to reconsider or take up additional action, we do it afterward?
That's fine. I see a path to completion.
So what are we doing?
Representative,
Withdrawing the-
right now we're listening.
Withdraw the motion to reconsider.
We're going to wait. Representative Mooney has us waiting in this model. So we're going to hear what our guests have to say to us.
Mr.
Let
Chairman.
me guess, you're in favor of the family planning money?
Yes,
Okay.
I am.
And
Mr.
you don't have
Chairman-
any offsets? You don't have an idea where I'm going to get the money?
Well, I do. I have plenty of ideas. Do you want to hear about them?
I do, actually. Hearing
Reverse
the
the
offsets.
revenue reductions that you made in the last few sessions.
Yeah, I can't do anything about that. You know, the way we work is we get a amount of money planned on by the Ways and Means Committee. It's distinct from us. We get a number. Our rule is we
I
can't
understand.
exceed that number. So I have to find a way within, and that's not one of them.
So, Mr. Chairman, members of the committee, my name is Christine Stoddard, and I represent Bi-State Primary Care Association. We represent the 10 FQHCs, federally qualified health centers in the state of New Hampshire. There are not 40, sir, there are 10.
Thank you.
And this is, go ahead and introduce yourself.
Thank you, Mr. Chairman and members of the committee. My name is Gregory White. I'm the CEO of Lamprey Healthcare in Nashua, Newmarket, and Raymond. We are a federally qualified health center serving the southeastern corner of New Hampshire. We are a family planning contractor with the state of New Hampshire. With our funding, we serve so far this year 1,009 patients for these services. This funding touches 22 positions in our organization, and while it funds none of them in the entirety, providing services to those without resources, were this funding to go away, it certainly undermines our capacity to provide services to the broader community. So those who are resourced or those who have insurance, I can't keep up with the rates that I'm paid for those services. So my fixed funding comes in to subsidize. Were these services to be defunded, that becomes free care. And that's now a burden on all of our fixed sources of funding, which are static and diminishing.
And
So, go ahead. I don't want to interrupt you. I had something to say, but I can wait.
thank you. Mr. Chairman, last fall you asked during a fiscal committee hearing what we could do to help the health centers not go into the red. This is a perfect example of many of what the state of New Hampshire can do to not hurt the health centers and their patients. These community health centers exist in areas of the state that are medically underserved. That means that their patients have to drive a very long time to get health care. One of the other family planning clinics in the state is in Coos County Family Health Services. They have the highest poverty rate in the entire state. They also have the highest rate of sexual assault in the entire state. The family planning clinic at Coos County Family Health Services also operates the Domestic Violence Support Center. Those two programs work hand in hand to keep survivors of domestic violence safe and healthy. Without these funds, those programs close and people lose access to health care because the community health centers can't afford to keep increasing their uncompensated care. What happens is they reduce services. And I'll stop if you wanted to ask Greg a question because I could go on for a long time.
I kind of wanted to just have a conversation with y'all. Okay,
Sure.
so you know, in the past two budgets at least, and probably long before that, this committee has recommended full funding of
Yes.
this line, right?
Yes.
So I think those of us who've been around for a while understand the importance and criticality of the role that you play. The issue I've been struggling with is that we have 75 cents on the dollar from what the governor spent. And in my head, as I prioritize those things, I'm looking at those items that have a direct care impact. If the state has a patient in one of our beds, we have to make sure that an adequate amount of care is provided for them. So that means we have issues like with Glencliff, where we know we have a personnel shortfall that we'll talk about later. By the way, I think I have a small solution. Small, but we have Glencliff, we have the New Hampshire Hospital with $4.6 million in personnel shortfalls. We have the YDC. We have a litany of direct services, and then you go into the developmentally disabled, and we provide a tremendous amount of care there. So in terms of direct obligation, direct responsibility, I just think that there's, in a rational model, there can be a case that the family planning, as important as those services are, critically important, that there are still nevertheless alternatives to that care. That providing free care from state funding is nice and preferable and has been our past, but if they can get the care that they need somewhere else, or pay you so that you guys can be a break-even business, we don't have any limitations on people coming in from Vermont or Maine or Massachusetts to use our services. So this is just an area that seems to me to have one of the least strong arguments. Not that it's not a great service, but I'm just in a short budget situation. That's where I'm coming from. And you don't have to agree with that. I don't expect you to. And you're now free to say whatever you want to about what I just said.
Actually, in some ways, I do agree with you. We operate as a business ourselves, and when we are faced with a Ways and Means situation that provides us 75 cents on the dollar, it means lack of services and cutting jobs. I would also point out that were we able to get break even from any of our patients, quite honestly, we wouldn't exist, because these folks don't have the resource to be able to pay for those services. So if it was an economically viable model, somebody else would already be doing it, and our existence would be not necessary.
But it is difficult to compete with free, right? I mean, the fact that you provide a free service means that you probably get some volume of traffic that's there because of the cost, the personal cost to them.
Well, the volume of traffic is there because they can't go anywhere else. They're expected to pay at out-of-pocket rates that they honestly cannot afford. 70% of our patients live at or below 200% of poverty.
Yeah,
that's not affordable.
So, did you have a comment? Is your hand sort of semi up? No. I've just tried to lay out in my head how I've gotten to this priority, and if I had 100% of what the governor had, I'd be all over funding this.
So I hear you, and my questions, which I'm going to direct your way because you could probably answer better than me. But my response to this, I wrote down two things: is you're saying there are places for alternative care. Well, where can they get care? And you're saying maybe they just need to pay. Well, I know these patients cannot pay. So my question to you is, what is the alternative for these people who are living at poverty level? For example, where would you go to get an IUD? You can't just go to a CVS Minute Clinic to have that kind of procedure done. Where would you go to get birth control pills, a breast exam? What are those alternatives for someone who doesn't have insurance and or cannot pay?
We are that alternative.
And in Coos County, they're the only primary care provider. There is nowhere else to go. So what happens is teenagers get pregnant and our teenage birth rate goes up. People get sexually transmitted diseases because they can't access condoms. People are going to have sex. Why can't we provide them with the tools necessary to be safe about it and smart about it? And I am from rural America. I had teenage friends that got pregnant. It's preventable. And that's what we're asking, because you don't want these patients going to the emergency room, which is very expensive and also adds to the hospital's uncompensated care. I realize that you have tough budget choices, but this choice, all of your choices really, have long-lasting impacts on the lives of your constituents. And we would ask that you find alternatives to pay for them.
All right. Thank you, Representative Priest.
Thank you, Mr. Chairman, and thank you for being here. You've given us like a snapshot of 1 month of how many patients you have provided service with. Do you have like a number for 2024 of how many patients that you provided service with family planning services for all of these 10 centers?
Representative, there's only 3 community health centers that participate, and it's well over 2,300 in 1 year.
So Lamprey Healthcare provided services under this contract to 895 individuals in 2024, and we're at 1,009 so far this year.
Thank you.
More questions from any member on this? Is there anyone else in the gallery that wants to speak on this issue? Do you have any other remarks? You've made your case well. Your case has won out the day each of the last 2 budgets. I think one of the more recent budgets, there was an addendum to make sure that the long special IUD that only Planned Parenthood was handling, that we funded that too. So this is not meant to be an unfriendly issue. This is just, we have unlimited wants, we have limited resources, and somebody's got to make hard decisions. So Representative Woolner.
So I heard you say something that really sort of sparked my interest all of a sudden. So if these services aren't available through the clinics that you operate, do you anticipate that people will use the emergency room in order? I mean, it's so costly to go to the emergency room.
What usually happens, Representative Wallner, is people delay care until it's an emergency. So imagine someone who could have been screened for cervical cancer who wasn't screened for cervical cancer until she's in horrific pain and turns up at the emergency room. And Greg has many examples.
I think it's just the argument for primary care is that prevention is a lot cheaper than treatment.
Great. Thank you. So I think there is cost savings here.
Definitely.
Thank you.
All right. So what I'd like to do with this is there's actually kind of a happy phase to this conversation today. There's maybe some money that we found that I want to go through that, and then we can have a vote on whether or not to reconsider 17. Okay. All right. Thank you. Appreciate you coming. Okay. So on the second page of the HB2 amendments, I see a new 1392. This is on the suspension of the WIC farmers market. I'd like to have us talk about Amendment 1392.
Do we still have a motion on the table?
No motion on the table. We're gonna come back around to it. It is line, it's the only number 46 I see. And I'm having trouble finding the amendment though. Is it the oh, there it is. Okay. So I think what we did in our last discussion is we asked Mr. Ripple to get an amendment, and the amendment to the amendment is before us. And it basically says that the WIC's farmers market shall just be suspended until such time as the commissioner can find the money to implement the program. And I actually thought we had voted on this, or that we had gotten close to a vote. Is there any discussion by the members? Do you know of anyone in the audience who wanted to speak specifically on this amendment?
I actually don't, but I just to refresh our memory, when we discussed this in the SNAP incentive program, I brought this proposal up near the end of that conversation because the line item as written was to repeal the program entirely. And I felt like the department had already invested so much time already in this current biennium to get the program up and running this summer, which was the plan,
Right.
that it was a real waste of resources that had already been focused on this program. And I had hoped that if we could not find the funds, that perhaps we could just simply suspend the program, keep it alive, keep it on the books, in the hopes that the commissioner could find some funds, or we can readdress it next biennium.
Oh, thank you for the clear reminder.
And-
Appreciate it.
As far as language, sorry.
Oh, go ahead.
I had simply asked, Ms. Tilley had suggested just a line of language that I had sent on to Kevin, and I just want to clarify with him that he incorporated that suggested language.
So I had seen, let me just take a look here.
So Commissioner Tilley, do you see the language on 1392? Does that read right to you?
Mm-mm.
So I hadn't seen specific language from Ms. Tilley, so this does not include any suggestion.
Thank you, Patricia Tilley, Associate Commissioner. And yes, I did not send specific language, but I think that this provides flexibility to the department.
So you're okay with this language?
Yes.
Okay. All right.
I think I just maybe dashed it together in an email, and I didn't put it on with your name.
Oh, okay. So are we ready for a motion on this? What's your motion?
It ought to pass.
Second? Second. Show of hands if you're in favor of passing 1392. Show of hands if you oppose. It looks like 9-0. That was seconded by Representative Tulersky. Okay. So
Thank you for that.
No problem. Thank you for the suggestion and making it happen. So that was 46. We did the first 54. We did the next 49. Then we did the next 44. So I think we're on 47, which is Amendment 1395. And this delays and fund 3 positions. So find 1395. How deep into this packet for whoever found it? Halfway? I've never been good with paper. That's why I was so happy when computers were invented. 1395, got it. So this was a refresh on another bill, which is why I think on line 7, the date got changed to an implementation of January 1, 2026. We want to take 3 unclassified staff. Is it all our staff positions are unclassified, right? That's the right category now? Okay. 3 unclassified staff attorney positions, purposes of providing court-appointed counsel to out-of-home placements. This was one where it was presented as though we thought that by doing this, given adding to the due process of these kids, that we might be able to divert some of them into closer to home, less expensive care. And the rationale was that overall, the state taxpayer would see a net positive because we'd be spending less in the aggregate. I think that was the theory. Mr. Ripple, we probably have on a budget sheet the addition and the spending. Can you draw our eyes to that?
You don't, because there's no additional spending. This is not a new appropriation. It's funds being drawn from an existing appropriation in the operating budget. So that's on lines 15 and 16 of this amendment, where it reads from general funds appropriated to HHS from the accounting unit specified here, $155,000 in the first year and $310,000 in the second year shall be used for the purpose of funding these positions.
So within the budget, we're just redirecting the spend.
Correct.
Okay. Okay, so what I would like to be able to do, and I don't know if it's practical, but in 2 years from now, when this issue comes back up, I'd like to be able to see what the impact was. How many kids through this due process consideration actually were affected? If the flow of the children stays exactly the same, but we're putting 3 more people in the loop, that buys us nothing, right? So is there a way, and I guess this is a department question, is there a way to keep track in this budget year of what impact these attorneys might have on the out-of-state placements?
Good afternoon, Marie Noonan, DCYF Director. So yes, we are able to and do track placements of youth, specifically out-of-state youth. There are a number of activities aimed at reducing out-of-state residential treatment and in-state residential treatment. It might be a bit difficult to untangle whether it's a result of these attorneys or other efforts, but we will certainly be able to show data regarding the efforts made.
Right. So this is new. This is a new function, though, right? So it's
Yes.
a new process that has to be integrated into your workflow.
Yes.
And so I'm hoping that in that new workflow, we could capture the data at that point of impact. But that's an operational thing. I just want you to know that if we're doing this in 2 years, somebody's probably going to ask you, okay, what difference did that make?
Absolutely.
And for now, we're trusting your judgment and the judgment of the department and basically supporting you.
Yes. We will be able to show data regarding hopefully what we'll see as a decrease in children in out-of-home treatment.
All right, and that's better for the children too, just to get that in there. This isn't all about money. Except right now it feels like it to me, but are there any other questions from the members on this issue for 1395? Do you have anything else to say?
I don't.
Is there anyone in the audience has anything to say on this issue? I'm not seeing any. I think we're ready for a motion.
Mr. Chairman, I move that we approve Amendment 2025-1395.
I believe it's 1395.
1395H.
Yes. Second? Okay, I think we can do a show of hands. If you're in favor, you'll raise your hand. Okay, thank you. So that's 9-0. Okay, so that takes us to line 48, or Amendment 1391. And so it's the next one. Don't flip. There it is. Okay. I'm going to call this the Wallner Amendment since your name's on it. Representative Wallner, do you want to remind us what we're doing with your amendment?
It does, well, it actually does a couple of things. It requires the Department of Health and Human Services to report to the Fiscal Committee on a regular basis, quarterly, the amount of funds that have been expended on childcare, so that we can track whether or not we're getting close to needing to have a wait list. And to the extent possible, to use TANF funds for needy families to cover any shortfalls.
Now, I remember in the budget line, there was $7.5 million each year of potential TANF, and so can we just have a quick conversation about whether that $7.5 million of maximum TANF, is that a ceiling, and what do we think the real amount might be?
This actually refers to the program where families receive funding to purchase childcare. That's what this is about. This is about the actual purchase of childcare slots for low-income children. This is different than the other one. Is the $7.5 and $7.5 million are a workforce fund for childcare providers. It's a different.
Right.
It's a different program.
But isn't the impact of this amendment to basically turn some TANF money into a safety net, and if we start to run out of money?
Yes.
And so I'm just trying to figure out if there's a maximum on the safety net.
I believe that I actually think that the federal government sets the maximum at 30% of the grant, so that it's already set that they can use up to 30% of the TANF funding that they receive from the federal government. I think that's what I understand, at least.
Okay. Does the department have any issues with this amendment? All right. Is there anyone are there any questions for the members? Any comments from the audience? Not seeing any. I think we're ready for a motion.
I'll make a make a motion to approve Amendment HB2 1391H.
Second.
I'll second.
By Wallner.
Mm-hmm.
I think we could do this on a show of hands. If you're in favor, raise your hand. If you're opposed, raise your hand. 9-0. Okay, so now we're going to line 45, 1363 is the next one. This is an HB2 that basically, in order to make sure there's opioid abatement funds available to transfer in the new fiscal year to cover the Governor's Commission on Alcohol and Drug Abuse, this would have us not enter into any new contracts or to terminate contracts that start after May 1, 2025. Now the odd thing to me, and I think I've heard this before, but it may be odd to other people who haven't, is since this law doesn't go into effect until July 1 and it's retroactive, what impact do we think this may have going retroactively back to contracts that have been let? Do you want to talk to this, Mr. White? And then the other part of that, the part B, is there a way, if this looks like the House is going to pass it, to start administratively tightening down how many contracts get let in this area?
Sure. So the existing state law, as it currently stands, the Opioid Abatement Commission directs the department to enter into contracts or conduct solicitations using the funds that are in the Opioid Abatement Commission fund. And currently, we have tens of millions of dollars that are either set up to go into RFP. We have a couple dozen contracts that are planned to go into effect in May 3rd or by July 1. And so technically, from an unobligated balance perspective, there's 30 some odd million. But once you kind of take into account the fact that we've been directed to do these things, there's only like a couple million, like $3 or $4 million that has not been obligated. So what this amendment does is it would direct the department, if we were to enter into any agreements prior to that July 1 date, basically after the budget would pass, to terminate all those, to liquidate those funds so that the Governor's Commission could be funded. Otherwise, we enter into sort of unprecedented territory where during the budget process, you had a commission that had the authority that directed the department to obligate all these dollars. And then you'd arrive on July 1 where you'd have insufficient funds to cover the $10.7 million in other funds each year within the Governor's Commission. And that would be certainly a unique situation that I don't think we've ever seen before. Right. And so I believe this is the intent, to make the policy clear of the committee, given the timing issues.
Right. So under current law and the process, only the Opioid Commission has the ability to throttle back and say, hold off on some contracts within the rest of the year.
That is correct.
That's their decision.
Exactly.
Right. Okay. In the first year of the budget, we are counting on 10.7 million from this fund. And I've heard a few times that fund continues to receive new settlements. Do you have a judgment about whether or not we're probably secure on at least the first year, and that the incoming funds should be adequate to making sure we're good on the second year, both at 10.7 million?
I think it's hard to project. So under the existing state law, we have a pretty good sense of what the Liquor Commission is estimating for gross profits. The money that the Opioid Abatement Commission receive, it comes in waves based on actions by the courts and determinations. Right. So while we would expect to see some additional revenue come in, the tricky part is we don't know how much, and we don't necessarily know when and at which point. And so from the way that the Governor's Commission operates, there could be challenges if they're making decisions in the fall and in the spring, and they arrive at the fall point, we haven't received any money. They can't necessarily then go and make a bunch of funding decisions if we actually don't have the funding yet. Right. So it would certainly present new and unique challenges that we haven't seen before.
Yeah. Okay, so some risk comes with this.
Yes.
And I think you've laid them out. Are any other risks that we should know about that you've not articulated?
I think the key one here is just sort of the conflict with the existing law and then the future potential position of the House.
All right. Questions from the members? Representative Wallner and Priest, you have your mics on. No. Okay, anyone from the audience that cares to speak? All right, so I think we're ready for a motion on this. I'll move ought to pass on 1363. Is there a second?
Second.
Okay, so let's do a roll call.
Mooney, on the motion. on
Your mic.
1363. On the motion, ought to pass, Edwards and Mooney seconded on 1363H, line 45. In favor, Mooney,
Yes.
Daniels,
Yes.
Seaworth,
Yes.
Nalavanko is a yes. Tolarski,
No.
Wallner,
No.
Stringham,
Nope.
Priest.
No.
Okay,
Yes.
and Edwards, yes. Motion ought to pass 5-4 in favor.
All right, thank you. Representative Priest.
I know this is after the fact, but is there someone from HHS who could give us a number of how many contracts that would be and the dollar amount?
I'm going to defer an answer to that
Okay.
because we've already moved the subject and
That's acceptable to me. I
we
was
have a
just curious.
timeline. I think
Okay.
they have some data and maybe by the time we leave, he can
Okay.
shoot you an email or something.
That's acceptable.
All right.
Thank you.
All right, thank you. Line 50, 1412 is next in the packet, relative to the youth risk behavior surveys. Yesterday, the House passed a House bill that dealt with this topic, and it added a particular set of sentences. It does not change the opt-out. What the House bill did, what's the House bill number that passed yesterday on this? Do you know, on the youth? That's okay. It did pass, and so what we did was we had looked at this amendment earlier this week, where guidelines on how to properly conduct an opt-out were written, and with the addition of the HB that passed the House yesterday, it also essentially added or created a requirement to basically publish the questionnaire, but for some reason I'm missing the line that says that. I guess it's line 12. School districts shall notify parents and guardians via email and/or other means of delivery deemed appropriate by the district of both the youth risk behavior surveys, opt-out provisions, and the lack of negative consequences for exercising, and shall notify the students of such information. Didn't HB2, didn't that HB though say that they had to make available the questions online? I think we have to find that one. Okay, thank you. So I'm gonna defer on this because we have to figure out what the HB said. I sent you a snip of it. What do you recall what snip I sent you in?
So I think I can find it. I think OLS had some concerns that it didn't work in the context of the bill, and that's why it was drafted the way it was. But I will try to find that language.
So I was intending for it to be an additive process. The provisions around making sure that people knew that they could opt out without consequence, that concept, along with what the HB did to require disclosure of the questions being asked. And I'm only seeing part of that here. I'm going to skip this. We're going to come back. Representative Mooney is going to figure out which HB got passed yesterday.
Sorry.
Yes.
I don't mean to, I'm reading the first amendment that we approved on Tuesday.
Okay.
Because I was trying to do a side by side.
Right.
And it says on line 16 of not the one we're looking at now, but the one from Tuesday, the school district shall make all non-academic surveys or questionnaires available at the school and on the school or school district's website for review by a student's parent or legal guardian at least 10 days prior to distribution. So to me, I read that as it's available and you can review the questions.
So what that may be the case. I'm not able, I don't have all the data in my head right now. I'm just trying to tell you what I wanted to do. I wanted to make sure that since we passed that House bill, that the key sentence that came from the House bill came into this amendment, along with what we already had to start with.
And I'll correct myself. It is in the amendment in front of us, that same exact language, because it's already in statute. So I'm just was trying to do a side by side, but I see that whatever language you wanted didn't make it in there. So sorry to take an extra minute.
No, you're fine. I actually appreciate everyone's patience on this because there's a lot going on. This is feeling very much like the last minute, and we don't even have brand new stuff yet. What bill is it?
House Bill 446.
Okay.
If you have your calendars, it's on page 51 from last week's calendar.
Would you pull up what passed the? Four, 6. And then it says as amended, so let's click on that guy. And then what's this sentence? So, okay, so from the House bill, the new language after student's parent or legal guardian read, and shall notify parents or legal guardians by sending such survey through email and any such other means of delivery that the district deems appropriate. Is that in here? In the HB2?
So no, that language did not make it in, and I think there was some confusion.
I'm actually seeing it. I see line 12. School district shall notify parents and guardians via email or other means of delivery deemed appropriate by the district. Oh,
Well, I think the question was whether it applied to the opt-out notice or the survey itself. So in this case, it appears to apply to the opt-out provision, not to the actual survey. And so I think OLS and I were not sure what you intended, and we thought this was what you wanted, but if not, it can be revised.
okay. I wanted to do an addition. I wanted to take what we looked at Tuesday plus the bill to make sure that this amendment satisfied both.
Well, so I think the language beginning on line 12 was an attempt to satisfy both, but I guess the question is, was your intent to have that email notification apply to the opt-out provision alone or to the actual survey as well?
While notifying on the survey, they should just have the opt-out instructions in as part of that email. I don't see them as distinct or separate. I see them. I'm telling you about the survey, Mrs. Jones, and here's about the survey, and oh, by the way, you can opt out without consequence. That's what I think.
So I guess my question for you then is, do you think the language in 1412 accomplishes that, or should we go back?
Is the intent here to, screen down? Are they trying to get at?
Mr. Chair,
I think, go ahead.
1412H seems to be the same language as 1130.
Yeah. Yep. 1130, which was the prior amendment.
Which we took up on Tuesday.
There's no change between 1130 and this one? There's got to be some change.
There is. It adds via email or any other means of delivery deemed appropriate by the district.
So it is additive. Okay, so I think for my purposes, this is probably close enough. This is definitely in hand grenade range.
Okay.
Are there any more questions about this? We're going around a little bit. Representative Priest?
Yes, I was wondering if there was a fiscal note on this.
No.
There was not. Okay.
Representative Nelvanko?
Yeah, I just had a question about, probably because, it was a busy day yesterday. I thought 446, basically for surveys other than this specific one was an opt-in. Is that a correct?
No, opt-in has never been around this, which is much to my chagrin, but it kept it as an opt-out.
No, I thought the opt-out was just related to that one particular survey.
Well, in this case, it's, all other non-academic surveys are included in this requirement.
Okay, so that, I misunderstood what,
Representative Daniels?
Yes, along with Mr. Ripple's comment, no, I don't, I
that's a good one.
see that this amendment here is lacking the major thing you wanted in there, because it talks about that the parents will be notified of both the opt-out provision and the negative consequences, but it doesn't say anything about that the survey has to be given to the parents. Well, that the parents have to know what is in the survey.
Okay, I'm gonna hang on to this one too, so we can just look at it. I'm juggling too many pieces on this, because Representative Mooney has shown me in the House calendar where the intent of the majority was, in current statute, all non-academic surveys except for the Youth Risk Behavior Survey are opt-in. As amended, this bill seeks to remedy any inconsistency in statute and have all non-academic surveys opt-in. But when I read what got passed, it's still opt-out. That was a big thing. Where did this change to opt-in? It's still opt-out.
My recollection was it was opt-in except for that, was the exception, so, but.
Yeah, I believe what happened when we voted on the floor, we changed what was opt-out to opt-in. So now that conflicts with the amendment that you've got here, which, if dated later, could be switched back to opt-out.
All right, so this is what I propose. We're out of time, and because that bill is now going to the Senate as is, if I want to amend it, I'll go deal with the Senate to amend the bill that the House just sent them. So I think I would like to make the motion to withdraw from HB2 Amendment 1412.
Second.
All in favor, raise your hand. Opposed? Okay, so that's now 10, that's 9-1 because Representative Weiler has joined us. Okay? So
Excuse me, if I could just ask one question about that. So the committee had previously adopted 1130, which was the version of the same amendment, but without the means of delivery language. Am I to assume then that 1130 is coming out as well?
1130 doesn't conflict with HB 446.
I just wanted clarity on whether...
So remind me of how this works. If they pass a bill on the subject and they pass HB2, then somebody in OLS later has to merge them? Or does one overwrite the other?
If they amend the same statute, it would come down to effective date first, and if they have the same effective date, it generally comes down to which bill was passed later.
Okay, so I'd still like to withdraw this one, and to your point about withdrawing 1130 that we passed already,
yep,
I'd withdraw them both so that the Senate has clean copy, and to the extent I'm compelled to work on an amendment with them, I can do that.
Okay.
So I'm in favor of withdrawal of the two, the one that we passed Tuesday and this one. Okay. That was a 9-1 vote, but to clarify, we're now eliminating two HB2 items.
It was 9-1.
We're going to revote just to make sure everyone's clear on this.
Which, we
go ahead.
voting on the second one or the first one from Tuesday?
We just voted on the one.
Yep, got that.
Mr. Ripple points out
Yep.
that on Tuesday, we
Line
voted
11.
yes on
Yep.
the other one.
It's line 11, 1130H on the front of our paper.
So I'm just trying to pull them both out of
Great.
HB2 so that the Senate has clean lanes.
So are you saying we're going to do another vote on both items or just?
I'm
No.
trying to do it in one, just withdraw. both of
Perfect. I'm just keeping up.
Okay, I'm trying to
Proceed.
them. Okay, so
I'm
that,
trying to keep up here too. So we're gonna 1130H and 1412H. We're gonna do in one vote
yeah, and on a withdrawal.
on a withdrawal.
All in favor, raise your hand. Opposed? I don't see any opposed, so that's 10-0 to repeal both. So Commissioner Tilley, you're still free to do the right thing. Okay. All right. Say what? I guess technically. So line item 52, 1423, delaying the June 2027 MCO capitation. Okay, so these are new. This is a new item. So so where do we find 1423?
Did you purposely skip Amendment 1422, the one above that?
I don't think I did. Did I?
You skipped it.
Oh, I did. I wrote on the wrong line here that we're withdrawing. So thank you. So 1422. So this is a reduction of Medicaid provider rates by 3%, requiring DHHS to reduce the general funds by 17.5 million in the first year and 35 million in the second year. That should also be one of these items on the bigger sheet.
Yes.
Where is it on the bigger sheet?
It is on page 3 on line 45.
Okay, so there you can see the impact. So this is money that can help us shrink the back of the budget, and it can potentially give us a little bit of relief on some tight areas. But this is essentially new money. And the implication is that we're going to decrease Medicaid rates that we just got done increasing by 10% plus the governor's proposal, which was 3%. We basically raised it last budget cycle around 13 percentage points, and we're pulling some of that rate increase back with this proposal. That's 17.5 million in the first year, 35 million in the second year. Who in the audience wants to speak to this? There's obviously a lot of people that want to speak to this. Mr. Bradley, since I cut you off last time, why don't you come up and you get the first run at this? And then I don't know your name back there with the glasses. Come on up and you can sit down. I assume you're saying something similar if you don't know each other. I'm sure it's just coincidence that brings us here together.
Thanks, Mr. Chairman. Reminder, my name's Ben Bradley. I work for the New Hampshire Hospital Association. We represent all 26 hospitals in the state of New Hampshire, plus all specialty hospitals. I just wanted to provide, in addition to our main concern about reducing rates by 3%, our concern that hospitals relinquished a rate increase last time around, speaking to your point about last budget cycle increasing rates. Hospitals in particular relinquished those and said that needs to be directed to.
May I speak up there?
Certainly.
You're absolutely right. Because that was a major deal last year that the hospitals said, don't give us the money. We need you to send it out to the community. So you're absolutely right on that point.
Thank you, Mr. Chairman. I just want to make sure that whatever's proposed is reflective of those concerns. And secondly, if it does affect hospital provider rates, just a consideration for your projected Medicaid enhancement tax revenue and what that looks like. Maybe the Medicaid director could speak more to that.
Right.
But it will have a balloon effect if you push here,
Right.
what that means elsewhere.
So I'm wondering if we can do some math on the fly. If we exempted the hospitals from this 3% Medicaid rate reduction because they volunteered to be frozen last budget cycle, I think that would be fair. But what would be the financial impact of allowing the hospitals to be exempt from this item? You don't know the answer.
I don't have the answer.
I'm sort of looking at Mr. White. You got.
May I just make clear, Mr. Chairman, I think it goes without saying we do have concern about the general 3% reduction, not just on hospitals, and the effect it would have.
I can't hear you very well.
Just the effect, the 3%, not just on hospitals.
Right.
But I want to make
Your
clear that
concerns from last year about making sure there's a healthy community support network around you, I'm sure are still valid this year.
Thank you.
Yeah.
Sure. So I would need to conduct a little bit of analysis, at least 30 minutes, just because we're talking several $1 million, and that's a lot to be off. I don't want to give an off the cuff number.
No, that's more than fair. And even if it's not exactly right, if we move this, by the time we move this to full finance, we could make a correction if we needed to. So it doesn't need to be perfect today, but I do want you to be comfortable with it. And Mr. Ripple, I'm thinking that for 1422, we may want to find the language to exempt the hospitals that didn't want the rate increase last budget.
So the language from the last budget excluded rates for hospital inpatient and hospital outpatient services. So we could potentially use the same language for this to exclude them from the decrease.
Let's be thinking, we still need to discuss it, but I wanted to say to the committee, I'm thinking that before we consider this, I'd like you to consider an amendment to this so that we allow hospital inpatient and outpatient to be held harmless by this reduction. Okay, Representative Stringham, you often have thoughts in this area.
Yeah, first, just a little bit of a history. We came into the last biennium in a period of, after a period of great inflation.
Right.
And previous two bienniums of below rate of inflation increases. So we were seeing significant cracks in access to service that was, crippling this whole system of care that we had. And, basically what I call the 25-cent coupon for a hamburger. We were handing out a lot of coupons that nobody could buy anything for. They took their hamburger coupon everywhere, and they said, you just said, take your coupon and give it to somebody, they'll give you a hamburger. And then they'll send us the coupon and we'll pay them the 25 cents. Well, they couldn't get their coupons filled. And a big part of the reason why we emphasized to at least keep up with the rate of inflation in the last biennium was so that some of those cracks would fall. And part of the reason why Mission Zero is getting much closer to its goal is because we shored up all these different Medicaid programs and the services provided and made some adjustments to the rates. Since we did that biennium, the combined rate of inflation in the last 2 years is about 7%. So we're already seeing a 7% reduction in buying power for the Medicaid rates if we kept them at 0%. If we raised them generally by 7%, theoretically we'd be where we were when we completed the last biennium budget. So the net impact in going the other way, and it says 3%, but it's actually 6%. It's 3% the first year and another 3% the second year. And in addition to that, we're going to have inflation these 2 years too. So we may be looking at as much, approaching 20% or 15 to 20% reduction in buying power for the Medicaid these Medicaid rates that we have.
What reduction in Medicaid buying power? What number did you use?
15 to 20%.
All right, got it. Thanks.
So I'm 7% inflation last time, 6% here, plus whatever the rate of inflation is in these next two. So what does that do? In some cases, there'll be access issues. People just won't be able to get the services. It may end up, is a good possibility, people will end up going to more expensive setting of care. Back at the hospitals, we'll be back having longer wait lists and the kind of dislocations that we were seeing before. We'll certainly see, with a decrease in nursing homes, that it's going to be downshifting to local property taxpayers, just as it was with the other change. Case of ambulance providers taking a rate reduction, which we know how vulnerable they are, we may lose more of them with these kind of changes. So, certainly the people who are on the various waiver services may have trouble getting their contracts fulfilled. So, it certainly, at this level will at least put us back to where we started the last biennium.
Representative Tversky.
Thank you. I just feel like this is a huge impacts so many different people. I'd love to hear what you have to say. And I also want to acknowledge that the CEO from Lamprey is still here. And we had a discussion earlier about an hour ago about how they have this unpaid services they provide to people who cannot afford it. And they have to then, of course, rely on these paid services to help keep the lights on. And by cutting it even more, what's the impact on those providers who are already providing care to our lowest income Granite Staters? So I'd just be interested in some more feedback from providers if they're in the room.
So these are just the first two people that were invited up. If there's third and 4 and 5, we're going to try to hear from everyone. Please introduce yourself and tell us what you think.
Yeah, thank you, Mr. Chairman and members of the committee. My name's Kelly Ann Totten. I'm the CEO with Granite State Home Health and Hospice Association, an affiliate of the Home Care, Hospice, and Palliative Care Alliance of New Hampshire, a member organization with nearly 50 home health, hospice, and palliative care agencies across the Granite State. Medicaid services such as Choices for Independence and Medicaid private duty nursing prevent more costly care. These programs serve the most vulnerable New Hampshire residents. CFI provides services to individuals living in the community who require nursing facility level of care, offering personal care services and assistance with activities of daily living that we may take for granted, like bathing, assistance with toileting, support with meal preparation, oral hygiene. Medicaid private duty nursing, otherwise known as PDN, cares for pediatric patients and adults living at home with complex medical conditions. It includes nursing services, sometimes around the clock, to manage complex medical needs, including patients living at home on ventilators, children with G-tubes. Their only alternative is a more expensive residential location of care. As you're all aware, prior to the last budget cycle, CFI had been underfunded by $153 million, leading to provider closures and service gaps. With the rate increase in the last budget cycle, home care agencies were able to improve workforce retention and begin to increase access to services. A 3% reduction in Medicaid rates would undoubtedly harm an already undercompensated and highly relied upon sector of the healthcare system. Already, the inadequacy of Medicaid reimbursement rates for forces home care agencies to supplement their Medicaid funded services through other means or to eliminate those service lines completely. One member agency subsidized over $1 million in Medicaid care. This is not a sustainable model, and most of our smaller members would only be able to close in that instance. Failure to adequately fund these programs, and by extension, this workforce, will result in those workers moving to non-competing industries like the food industry and retail, where they can receive better wages and have a less taxing job. The net result of this is that most vulnerable Granite Staters will be left without care and will take up beds in hospitals and nursing homes, bogging down the system of care. A strong home care system benefits the entire healthcare system. We've heard a lot about that today. I worked for 20 years for a direct service home care agency. My position allowed me to work with first responders as well as hospitals, as well as primary care offices. When people do not have the right services in place in the home environment, someone is using up 911 in an emergency department because they can't get out of bed in the morning to start their day. It's avoidable and preventable by at least protecting the rates that we have for these Medicaid services in the home care setting.
Thank you. Anyone else? Mr. Ross, it looks like you were wanting to speak. And if you want to speak on this subject, would you raise your hand so I can schedule you a little bit better? Okay. All right.
Thank you. Again, David Ross from Hillsborough County Nursing Home on the behalf of the New Hampshire Association of Counties. I won't repeat the concerns that others have shared. I will share that we have all the same concerns. The most significant concern for us from the county perspective is that this reduction will be an immediate pass-through to the taxpayers. That will result, I know for Hillsborough County, just back of the envelope math, it'll be $250,000 the first year, $500,000 the second year will be a direct pass-through to our taxpayers, which given current burdens on them is going to be significant. But our great concern certainly is going to be for CFI providers in home health and being able to support a shift of folks and the proportion of folks receiving community-based care. The state has done a wonderful job in directing resources there in the last budget cycle, and it was able to help stabilize the home and community-based care environment. I would hesitate to see anything that would detract from that, but I do appreciate the challenge that you were faced with this budget cycle, so thank you.
Thank you. Ms. Stoddard and Lamprey. From Lamprey, yeah. That's all I could remember.
Once again, thank you for your time. Greg White, CEO, Lamprey Healthcare. I just wanted to point out and echo my earlier statements. We're an organization that weaves together many sources of funding, Medicaid being one of the largest. We're a primary care provider. Cuts in rates would certainly impact our ability to provide primary medical care, primary behavioral health care, substance use treatment, prenatal care, and OB care. We do weave together many sources of revenue from the state, from the federal government, from local resources, from private payers. We're going into a period of time where a lot of those resources are in big question, and this concerns me. Back of the napkin type of calculation, over 2 years, this would be about a $500,000 reduction for us, assuming.
May I ask you a question there?
Yes, sir.
When are you doing your next budget? Just get me oriented to where you are in your budget process and where a July 1 change, where that fits in with your budget cycle.
So our fiscal year starts in October, so we are going into starting next year's budget right now.
Okay, so if this were effective July 1, it would be hitting your current budget.
Yes, it would.
Okay, that's what I was looking for.
Yep.
All right. do you have, I interrupted you, but.
No, no, I mean, I think, again, just echoing my earlier statements, we don't run a big margin, and we've not over the last few years. So every one of these changes has a high sensitivity impact to our organizational capacity to provide service. So.
Ms. Stoddard?
Thank you. One of our members said the other day that this is like death by 1,000 cuts. The community health centers and other Medicaid providers are getting hit by all sorts of grant reductions and eliminations. The health centers and Bi-State just had grants revoked earlier this week. Every time the state reduces their revenue, services suffer. And the governor said, I believe last week, that opioid use disorder deaths have decreased 35% in 1 year. And that is because of what you all did, right? You increased Medicaid rates. It had a huge impact on substance use disorder treatment. Without Medicaid, there truly can't be a substance use disorder system because most of the people in that system are accessing substance use disorder treatment. And so when we make these decisions, like reducing Medicaid rates, please know that there is a direct impact to mental health services, to substance use disorder services. And I'd also say that the community health centers across the country save Medicaid 24%, which is $68 million and almost $150 million to the total healthcare system. I respectfully request you find the money elsewhere because people will be harmed. Thank you.
We're going to look at some elsewheres later, but it's not anywhere near the needs, but we're looking. Mr. White?
Sure. So just based on some quick analysis, if you were to pull the hospital rates out, it's about 3.05 million in state fiscal year 26 general funds and 6.1 million in state fiscal year 27. Oh, apologies. That's total funds. So it would be approximately a little about 1.525 million in state fiscal year 26, and then 3.05 in 27 general funds.
So, okay, so that's relative to what we were projecting, 17.5 million in 26. You're saying it's about $1 million less than that. So the real number, if we exclude the hospitals, would be more like 16 million and change.
It would be a reduction of about 1.5 million in the first year. So about a little less than 16 million in the first year. And then from your 35 million that I'm looking at here, it would end up being about 26.5 million.
26.5.
General funds only.
Right.
Sorry, just to interrupt. So I thought the general fund impact in the second year of removing the hospitals would be 3 million. So
3.5.
3.5 million?
Yeah.
Or 3.05 million?
So my first statement included total funds. So I'll just say it again. So the first year would be approximately $1.525 million general fund reduction. The second year would be approximately 3.05 million in state fiscal year 27.
So if the committee were to make those changes, the general fund reduction in the second year would be just shy of $32 million.
That's what I was tracking. So, right? About 32 million in the second year?
Yeah, sorry, I'm working off an envelope here.
Yeah, no, you're doing great. Okay, Representative Wallner?
Yes, I don't know who I'm directing this to. I think to Mr. White, but why is our sheet here not showing any federal funds?
I didn't prepare it. I don't know.
That's the sheet that Kevin produced for me, and I'm managing the general funds. I have to hit a general fund target, so he did that at my request.
Okay.
Go ahead.
So really, when we see a number of $17 million of general funds, it's really a loss of $34 million because we lose all those federal funds also.
Unless we were matching it with higher rates in other areas. So it could be slightly higher federal dollars.
Okay. So this isn't really the way this is written, it is not really a true picture of the loss of financial support we have for the providers.
Yes.
Thank you.
I'll accept that. I did that intentionally because I'm just trying to get everyone to focus on the fact that we have a general funds problem.
I would just also point out that in the status column, there's a note for this and the next item that says there's no specific budgetary reduction to federal or other funds, but such funds will be reduced in practice as the rate decrease is implemented. And the next item should say the same, but relate to the delay in MCO payments.
So thank you. Ms. Kroll and I think Mr. Monahan, you both wanted to speak?
Good afternoon, Mr. Chairman and members of the committee. My name is Heidi Kroll. I work at J. Grimble Strategic Solutions, and I represent.
Could you speak up a little more?
Sure.
Okay, because
That
I'm deaf.
Okay, is that better?
Yeah, I'm going to turn this machine off back here so I can hear. It hits my tinnitus at just right frequency.
So good afternoon, Mr. Chairman and members of the committee. My name is Heidi Kroll. I work at J. Grimble Strategic Solutions, and I represent Life Coping, which provides home and community-based care services. They're based in Nashua, but have a statewide footprint, and they provide specifically case management services. So their staff are the folks who, when somebody has been deemed eligible for Medicaid services, they work with that patient and their family to figure out what services are necessary to keep them home safely and staying healthy, and work with them to try to find the providers who can actually come into the home and provide the services that the client needs. So we are concerned about the proposal here. I just wanted to say, I don't know the exact number off the top of my head, but I believe that it had been at least 10 years prior to the 3% rate increase that was granted in the last budget cycle. I believe it had been at least 10 years since there had been a rate increase. I know it had been a significant amount of time. So to Representative Stringham's point, lots of years of inflation, but not being reflected in kind of Medicaid rates kind of keeping pace. So for Life Coping, as an example, their health insurance continues to go up. Their property taxes, they pay business taxes, and they have done their very best to take the rate increases that they got in the last budget cycle and put those into higher compensation for their staff because they want to retain their staff. So I just wanted to say that. And Mr. Chairman, you mentioned something about a 10% rate increase and then also a 3%. But at least from the case management perspective, I'm not sure that 10% was anything that we saw. So, and we agree with the comments that have been made by prior speakers as well. So,
Right.
Thank you.
So I was referring to last term's budget where the governor started with a 3% Medicaid rate increase, and this committee took something like 10 percentage points to add to it. And Representative Stringham, you probably remember this better than I do because you built the spreadsheet to distribute that money. So I think everyone but hospitals got some of that 10%. I'm not arguing. I just want to make sure I understand the situation.
Okay. I didn't recollect that, but I also haven't had a chance to talk with my client because things have been moving quickly.
Right,
so
right.
Subject to check.
All right. So the intent was to give pretty much everyone in the healthcare system, except for the hospitals who stepped back and said, give it elsewhere. Well, the intent was to get the 10% out to everyone. And if we didn't do that, I'd like to understand it better. Mr. Monahan?
Thank you, Representative members of the committee. I'm Jim Monahan from the DuPont Group. As the committee, members of the committee may be aware, I work to organize a group of Medicaid and other healthcare providers to engage around some of these issues. In a minute, I'll speak to the spreadsheet issue that you talked about. Let me just say obviously, as you can appreciate from a timing perspective, and I know that there's a lot of process after this, but with regard to being able to give you as complete an answer, reaction as possible, it's just not possible, not having seen this until very recently. That said, as you and I have discussed, we all have jobs to do, so I would expect that following, if this amendment were to go forward, the committee would be interested in the impacts that this will have to the system beyond what I'm going to share with you now, and I'll encourage people to follow up with members of the division and the finance committee. I should also say another frustrating part of provisions like this are reflected in the comments that Representative Wallner made, that on April 15th, New Hampshire taxpayers are going to contribute $14 billion to the federal government. And as it is today, we get less than $5 billion of that back. And to be leaving tens of millions of dollars, federal dollars, on the table because of decisions like this is particularly frustrating from, just that leaving New Hampshire taxpayer dollars on the table is frustrating. If we could find ways to avoid that, I think that's been the tradition of the budget writing process in New Hampshire. So in answer to some of the specifics you asked, I'm going to bounce around from a number of the folks I work with. From the community mental health center's perspective, and answer your question, they do July to July budgets. So, they are working on their budgets now, and this certainly creates some uncertainty associated with that. And I should also add, I'm sure the committee is not indifferent to this, but there are significant federal changes that are affecting their budgets as well, many of whom, saw very abrupt reductions in federal program dollars yesterday. There's a federal destabilization that's taking place. So a state destabilization makes it very challenging for the providers to do the work that the state asks us to do, which is to provide access to care that is required under the Social Security Act. In answer to a little bit of your question about the work that you did 2 years ago, I think the committee and the legislature should be very proud of that. You went many years with not paying enough attention to the rates that you provide payers. And so the mechanics of what was put together was 3% across the board rate increases. And then the committee put a lot of work into looking at 23 different payer groups to determine what was needed to ensure that they had stability, particularly with regard to workforce and retaining workforce. So while this step will not eliminate some of those provisions and just focus on the 3%, as Representative Stringham has observed, that stabilization is constantly challenged by inflation and additional people coming into the system. To a narrow point, but I think it's one important for the committee to consider this afternoon, is that if you move forward with some of the provisions on your worksheet, I see that there is a potential reduction in appropriations to the DD agencies. And that would probably translate into a rate reduction. So I'm not sure if the intention of the committee is to move forward with that rate reduction and then on top of that, do a 3/3 reduction to that provider group. So there's some disproportionality there.
I missed a turn there. You added in a second area where you're saying...
Yeah, I know you haven't gotten to it yet, but my understanding, I think from the spreadsheets, is that you're proposing a reduction in the governor's appropriation to the DD agencies.
The which agencies?
The developmental disabilities agencies.
Oh, the DD, okay.
Right. So my question is, so that would translate, I don't know how much, into a rate reduction.
I know what you're saying now.
So I'm just it's your decision to make if you want to compound it, but I'm just flagging that something to take a look at. And then finally, and this is somewhat me connecting the dots. One of the aspects of the governor's budget that I observed is that they seem to work very hard to avoid any Medicaid rate reductions because of the destabilization. I have presumed that a part of the reason that the governor's office came forward with the cost sharing provisions around premium contributions for some of the populations and an increase in the prescription drug copays was to avoid having to dig into rates. That hasn't been articulated, but that's something that I presume to be the case, which is a tough deal to swallow. But I think it's something that was in some sectors the rationale for that cost sharing was to avoid the rate reduction. So it's disappointing that there wasn't enough. So and before you ask, I suppose you're going to say, so how are we going to pay for this?
If you have an answer, I'd really like to ask you.
I was counting, I'll check with Representative Wallner. This is the 18th budget that I've worked on for when I was a member of the Senate staff or here, and I sometimes see in the process that the all-powerful House Finance Committee is able to have a two-way conversation with the Ways and Means Committee. Oftentimes, and it's certainly the case this year, when the Ways and Means Committee makes decisions with regard to the amount of revenue that the state's going to have, they don't have the full benefit that Division 3 or other divisions have of what the cost to New Hampshire is, and in this instance, how much federal money is being left on the table. So they don't have the benefit of understanding that you have the potential to leave $300 million on the table by making the scope of reductions that you've brought forward this week. That's a fresh set of information I think the Ways and Means Committee didn't have, where they would be able to revisit issues like Representative Stringham's suggestion that revenues from tobacco and vaping and things like that could be brought forward for additional match. Easy for me on this side of the table to say that. I know the clocker's running, but I at least wanted to offer that observation that I'm sensitive to the fact that things have to be paid for.
Well, thank you. Thank you. Is there anyone else that wanted to speak on this subject? So just to try to come up with some context. In the past, Division 3 has recognized the long-term decline in the real value of our Medicaid reimbursements, and we tried to come up with a way to fix that in the last budget. This year's budget is just presenting us with a completely different environment, and we have to hit a number. We're going to have to hit a number, and that number will be hit by imposing a back of the budget reduction on the commissioner, so that over the next 2 years, she would have to find these savings somewhere. And what I'm wanting to do is to try to find a way to reduce that back of the budget cut so that she has a little bit of freedom of motion, and that we take some issues off the table so that she can focus better. That's the epiphany I had the other night. And the impact of not doing this is to leave in the back of a budget an extra 17.5 or 30 and 35 million. So that's a bunch of money that we'd be asking the commissioner to manage her way through in the next 2 years. And that just seems like it's getting to be a really big number. So we need to find, this is a search to try to find more revenue, is what it is. All right, did you have a question, Representative Tversky? It seemed like you wanted to say something. Representative Stringham?
I'm just going to add a little bit of color, I guess, to the previous testimony.
Yeah.
The roughly 100 million of Medicaid rate increase money, in part kicked off really by the incredible statement by the Hospital Association is, let's get the whole system working better. If you do that and we get rid of people who are stuck in our emergency rooms, we'll eventually save money, but the whole system will work better. And so we ended up, everybody else got a 3%, but we prioritized increases based on those that made the whole system work, where often we'd get benefits in 2 to 3 different Medicaid rate groups. And I think the overwhelming testimony has been that that worked pretty well. But again, I wanted to acknowledge the hospitals for getting that started.
Yep.
The other question I have is based on what you just said, and now that we have Chair of Finance here, do you want to reconsider the motion that we voted down earlier to fund Medicaid rate increases with partial cost of living increases in the tobacco taxes? Or you feel comfortable that we are where we are?
I think we reached the right decision.
It's fine.
If you want, you could try to make an argument for reconsideration, but I don't want to do that.
I don't want to waste my time.
All right, Representative Seaworth.
Thank you, Mr. Chairman. I just want to reflect out loud on what you just said about the back of the budget cut. To me, and I found all this testimony very compelling. However, I think much of that applies to back of the budget cut, but we don't know it. So any money that we force the commissioner to remove from the budget may lose matching federal funds, and it will cost people services that they depend on. So to me, it seems like any cut that we can put on the table to discuss and to go over through the rest of the process to be discussed as we have today is preferable to me than the opaque back of the budget cut that no one in this audience can understand exactly what the impact's going to be. So for me, I would like to, I don't think, especially big numbers like that, just throwing them back on the back of the budget doesn't seem like the best option for us here today.
Right. Representative Tulerski.
Thank you. I just had a clarification that I want from Mr. Ripple, because I think some of us are unclear. There's a line for the DD community that we're going to discuss in a little bit, and then we're talking about a 3% rate cut. So is that the way all of this is laid out right now? We're looking at the DD community getting that cut, and on top of that, an additional 3% rate cut in all services that they would seek to receive?
I believe the reduction in developmental services funding that's on line 44 is related to waitlist funding, so it's not specific to a rate cut. So they would get the 3% rate reduction across the board that's being considered in this item, but I don't think line 44 would come in the form of a.
Can we clarify then? Someone clarify for me. So if line 44, that's that spreadsheet, the green spreadsheet, the mystery spreadsheet that we've been looking at?
That's been overcome by events. We're not talking about that line yet, so I've not had an opportunity to update you on what numbers you're looking at.
Okay.
The green sheet is not part of this conversation today.
Well, I prepared for today to look at the green sheet, so I appreciate that.
Yeah.
So I guess when we do talk about line 44, I would want to discuss the impact of line 44 when we get there, with the 3% Medicaid rate cuts proposed for the DD community also, and to try to understand the impact of both of those. Thanks.
Okay. I think we're going to have to set this aside, because I think we're going to end up having to recess and caucus, check where we're at. What was the other one that I postponed having a decision on? I didn't star it. What? Yes, Representative Priest?
I believe it was line 17, deleting the family planning. We had a motion, but we didn't have a vote.
It's on, that's a different sheet. So where's,
Are we looking at HB2 items now or HB?
we're still looking at this long
Okay,
sheet.
so
and
that's on, so what Representative just referred to is a different sheet. So I just want to make sure we're looking at the right thing.
Okay, is there the Planned Parenthood, excuse me, family planning, on the sheet that's in front of us? It's not item 17.
No, that's on this. Family planning's on this.
Okay, and it's not, go ahead.
Was it this?
No, we did talk about that TANF money. Yeah, that was the Wallner Amendment. We agreed to do the Wallner Amendment. Yeah, no, there was on the Wallner Amendment.
I think the confusion is we looked at some amendments that are on the top part of the list on Tuesday, but then we revised some of them and we're now moving to the bottom of the list. Is that correct?
Well, everything that's gray, we decided already. So the white lines are the ones that we're still discussing.
Correct. So if you go to the front, line 9, repealing the WIC Farmers Market Nutrition Program,
Yes,
I believe that was also at the end of the list because we had a new amendment. So line 9
all right.
on the front we can take out because we dealt with that.
That's correct.
We dealt with it. And it says that in the status. It's pending resolution C 1320 or 1392. So we did 1392. So line 9 got overwritten by 1392, which is a different line, which is line 46.
Maybe.
So we voted on 46.
Correct. And I guess what I'm saying is when we're looking at outstanding items that we needed to do,
Yeah.
maybe we could just walk down the front and see if we replaced that item with a different amendment already today and then see what's left.
So I appreciate the suggestion, but I think I'm going to continue going down. We only got a few more line items in the method that we've been following. But your point is valid. We got to just double check this before we're through. I think we're on line, I want to set aside 51 for a while, which takes us to line 52. Delaying the June 2027 MCO capitation payments until the start of FY 28. So if you look at, on this one, the amendment, this is a new one. We didn't talk about this last week. Or I keep saying last week, it feels like it. It was Monday or Tuesday. So what the concept is, and this came from something that the feds did to me one year while I was serving. We always used to get paid at the last day of the month. And the last day of the month included September 30th, which was the last day of the fiscal year. And one year the Congress had to save some money. So what they did was they took that pay period and instead of making it the last day of the month, they moved it to the first day of the next month. By moving it one day like that, they were able to take a whole month of pay and put it into the next fiscal year. And I remember thinking, okay, it doesn't really affect me much, but it's kind of gimmicky. But remembering that gimmick and talking to some people, we can do something similar with the MCO capitation payments. We pay, if we postpone the payments by a month, and 27, in a rather gimmicky way, we generate 25 million to reduce our need to put burden on the back of the budget. So it's just a right shift of a month on those capitation payments. It's easy for me to say, just a shift in a month. Yeah?
Can I ask a question to make sure I understand correctly?
Yeah.
So we're just going to move that last month of the payment for this biennium to next biennium and have to pay for it then?
Move them all so that by the time you get to the last month of the second year, that's the payment that rolls into 28 that we're not talking about.
So we'll have to find the money for that next biennium.
It's definitely kicking the can down the road, yes.
Digging the hole deeper and kicking the can?
Or
Depending on how you look at
waiting
it.
for an economic miracle to sweep across us and make our revenue coffers flush. It depends on how optimistic we are about a booming economy in the next 2-3 years.
Concerns me.
Yeah, no. So that's what that does. That's 1423, and you can read it. Representative Stringham.
Thank you for bringing that forward. I guess the question is basically saying, if you pay cash, we're going to pay in June. If you put it on a credit card, we'll pay it in July, and therefore we get to put it in a different biennium. So my question is, maybe to Kevin, is that legitimate? And is this the right way to account for it in our financial system?
I don't know that I necessarily have an answer as to whether it's the right or the wrong way. I will say that it's something the state has done in the past, and it has worked in previous budget cycles.
Thank you.
Any comments from the gallery? Okay, so I think we could take a vote. And we're going to have to do a roll call on this. I move Amendment 1423 for inclusion in HB2. Is there a second?
Second.
So any further discussion? Go ahead.
I just want to ask a question. What happens? I mean, I assume we pay we fill the hole first. So like what potential, and I'm looking at Nathan over there, and I'm sorry to ask this, but like what potentially happens? I mean, we'd have to pay this off first, and then we'd have to pay the July month also. Like, I just want to understand better the risk we're taking.
Sure. So based on my reading of the amendment, what we would do is we would have 11 payments in state fiscal year 27, and in state fiscal year 28, we would have 13 payments. So the 12th payment that would have occurred in June, in late June, would occur July 1, and then we would have another payment at the end of July in state fiscal year 28. So the expenses would be incurred in the next biennium, and they wouldn't be budgeted for here.
Right, but it would increase the burden for us in the next biennium.
It would increase the burden, yes.
Yeah. Okay.
Or the can gets kicked another budget cycle. And we stick with 12 and 12 instead of 13 and 12. Or we do nothing and we put more money in the back of the budget. That's the problem. There are no great answers. I'm not happy about any of
I'm
those.
just trying to understand the implications before I
Yeah.
make a decision.
Yes, ma'am. No, it's fair. All right. So I think we have a motion. Is there any further discussion? Not seeing any. Will you call a roll, Mr. Clerk?
Mooney on the motion to include in House Bill 2, Amendment 1423H.
Yes.
Daniels.
Yes.
Seaworth.
Yes.
Nalavenko's a yes. Weiler. Tolerski.
No.
Wallner.
No.
Stringham.
No.
Priest.
No.
Edwards.
Yes.
So the motion is approved on account of
6-4.
6-4.
Okay. Number 419 on line 53.
$14.19.
1492 is what I meant to say on line 53. Basically, what this does is Mr. Ripple, I need a lifeline.
So this suspends for the biennium the requirement that the legislature fully fund a developmental services waitlist.
So the current law says that the agency, the department, is required to submit a budget that fully funds the wait list. I think a reading of that law could also be interpreted that the legislature is obligated to do the same. And in order to deal with that potential ambiguity, this HB2 basically would allow the legislature relief in this budget from fully funding the wait list. Keep in mind, historically, the wait list has been fully funded, but the actual utilization of the funds for various reasons, not all the money gets used. What's the dollar amount on this? What line item?
This relates to, sorry, line 44 on your budget spreadsheet, reduction in developmental services waitlist funding. A general fund reduction of a little shy of 8.9 million in 26 and 22.5 million in 27.
So to your earlier question about the green sheet, this proposal replaces that green sheet proposal.
If I may.
Yes.
So that other sheet, the green sheet, had lots of different accounting units
Right.
that had different percentages coming off the top. So from what I'm understanding, that proposal is being replaced completely with removing the requirement for the waitlist funding, which it's anticipated will bring in or cut, sorry, the cuts in the revenues and all that, will reduce our spending from what I'm looking at here, 8.87 in both general and federal funds in 2026. Is that correct? And then in the second year, 22.5, both in both general and federal.
I believe that's an accurate summary.
Back, that's about 50 million in 27 and another nearly 20 in the first year. Is that
I think that's correct
okay?
math.
I'd really, since the crisis of the wait list was before my time here in the general court, I would really like to hear from anyone who could speak to why we pushed so hard and so many people worked to get this provision into law to fully fund the wait list.
I think that's fair. I'd also like to ask, supplemental to that, is what is the perceived impact of this reduction? So yes.
Thank you.
So is there anyone, Ms. Hardy, do you want to weigh in on that? That whole wait list issue, that even precedes you though, doesn't it?
It sure does.
Yeah.
Thank you for the question, Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. So what appears to be proposed is, just as you said, Representative Tolarski, we've been mandated to fund our wait list, which is projections from our area agencies as to individuals who will be coming on to services through developmental services or people who need modifications or enhancements to their services. So this would, in effect, I think what it's proposing is to eliminate that requirement to fund the wait list, thus creating a wait list for services.
Go ahead.
I guess I just don't even know where to go from there. Can you tell me how that would impact clients, in particular, maybe young adults who are moving into the system and coming out of their school districts for services?
I think it's exactly that. So it's people who are new to coming on to DD services. It would be kids transitioning from school-based services onto waiver services. Any individual that may be moving into the state who require developmental services on the waiver. What it wouldn't do is hopefully impact people that are currently receiving services, as they're not part of the wait list, but it would be an impact on the individuals who are new to service.
Representative Weiler?
I thought I remembered money lapsing from this. Do you remember how much?
So there was a unique provision added this year to the DD account. So if you have the governor's operating budget, it's on page 1015. There are footnotes in 7100, 7016, and 7111 DDIHS and acquired brain disorder accounts that direct the department to utilize the carry forward funds. And so right now for the biennium, we're estimating approximately $80 million in total funds. And those dollars are applied to the 502 lines that you see in the budget today. So for example, at 7100, while you may see $419 million budgeted in that line, in reality, there's an additional $30 million that are being accounted for there. But in order to do that, to apply the carry forward, because it's off books and it's dedicated, you actually had to make a reduction. So what you're looking at in the budget is actually a lower amount than what is actually available. And those carry forward dollars are being applied for that purpose, for services.
So it's hard to judge from year to year how much we spend because we don't know how many coming on and off the list. So it's just a guess when we try to fully fund to keep from getting a wait list, which is why we had money lapse. Is that correct?
Yes, I would say with some of our technology enhancements and working with the area agencies, we're better able to predict and estimate people, at least aging out of or aging into services, but can never fully predict, people moving into the state and requiring services.
Thank you.
So Representative Woolner.
So even though I'm sure you weren't there at the time that the wait list came into being, you must know the history. You must have the history of it. And can you remind us of what the history of the wait list is?
Does Ms. Santinella, do you want to talk about the history?
Go ahead.
All right.
Certainly our community, the developmental disabilities community, fought hard to close Laconia State School. And part of that was establishing 171A for the rights of people with developmental disabilities. And so in order to transition folks from institutional care to home and community-based care, a lot of these provisions were created to ensure that people with disabilities have equal access to home and community-based services and, to choose the direction of life for themselves.
Okay, I think I'd like to have us address this after we take a recess and caucus. So is there anyone from the community that wants to speak on this issue before we do that? Come on up, sir.
Good afternoon, and thank you for the time. Appreciate it. My name is Will Walker. I'm from Hollis. I'm going to come at this from a family perspective. I have a son who's 26 years old with autism. He's been in the DD system since he's been 18 months old. I also lead a group of families of over 300 some families in the space. I work for a area agency called Gateways Community Services. So what I can come at from the family perspective is from the families that I talk to and the fear that this puts in them. Okay, the fear is this, is you have a child that's transitioning from in-home supports or from school age to adulthood. And what happens if there's no budget for them is that the parent is now the sole provider for this person. They become the responsible provider for the individual. It means that the parent would have to often quit their job to be the primary caretaker. Historical perspective, these are true stories that I've heard where people have had to take their children to the emergency room, a much more expensive option. We've had parents that have had to just drop their kids off in the waiting room at the area agency because they can no longer provide care. So cutting the waiting list here, I mean, the waiting list, it gives the parents the ability to work. It provides the care for the people. I'm sorry, you saw.
Will, I want to keep hearing you, but I just want to make sure that I understand the situation just a tad better, and maybe it'll help you understand it a little bit better. So maybe this is a Mr. White, Ms. Hardy question, but if we've got money from this current year that we think we're going to carry forward because we had fully funded the wait list this budget cycle, but we didn't spend it all, therefore we have a carryover in the next year, rather than fully funding a fresh wait list, we can recognize the carryover, reduce the amount of new spend, and we're still effectively got all the services covered. So I think that's the way this works. How wrong am I?
So the carry forward is already being recognized via the footnotes. So if those footnotes weren't there, then the budgeted amounts would be, in total funds across both years, would be $80 million higher. I would defer to Melissa, as she referred to earlier, on a number of the system changes and enhancements that have occurred over the past couple of years. When the DD accounts were originally created to be non-lapsing, it was just prior to the pandemic. The pandemic caused services to not be delivered for a variety of reasons. And it was during that time that you saw an increase in the carry forward amount really go up quite a bit. And what we've seen recently is we've seen higher rates of spending. And so the projections that are included in the budget and the amounts that are being reduced are based on the best data that we have available. So the governor added the amounts that are being reduced, that would be reduced by this action. And those amounts were the amounts that we projected based on the individuals that we are aware of that are coming into the system and certain assumptions around acuity and need. And so reducing these amounts would likely create that wait list based on the best information that we have available today.
So the bottom line is you're seeing an increase to the people not being served, effectively needing to go on a wait list.
I think with this legislation or this proposal, we would see individuals who are currently being served continue to be served. It would be anyone that would need an enhancement or new to service not be funded or go on to a wait list. As we know, we've been working on rates to control costs in the DD service, which were not funded. So we still have to pay. I think I reference Representative Stringham's 25-cent coupon, right? If I have 25 cents, but it costs me 50 cents, I'm still going to hold on to my 25 cents.
Right. So the reason I took this side road is because I wanted to validate whether or not the people who are hearing about this and you referred to as being fearful, it sounds to me if they're already receiving their services, they have nothing to fear other than how this gets presented to them.
I would say unless they need increased services or
but if
increased
it's
need.
maintaining the status quo with those services,
Correct.
They're fine. Representative Weiler.
When was the last time anybody was on a wait list in this program?
I believe it was 2020. Chris has the dates.
I'm Chris Santinello, Associate Commissioner. I was here probably sitting in Will's seat. September 30th, 2020, and we had 80 people on the wait list then, and then after that we have not had a wait list.
So I interrupted you. I just wanted to interrupt you long enough to just make sure I understood the fear issue, which is valid. And so I'll let you continue.
I'll be short. I mean, I think the fear issue is valid. Like for people like me, probably not, because my son's already in the system. He's already on a DD waiver.
Right.
Okay, but I have families that I talk to that are this year looking at a transition from in-home supports into the DD waiver. And if that were cut, they would then be on the wait list, and I know a person that said she's going to have to quit her job and become the primary care provider for her son. Okay, and we have examples like that. And I don't know if the department has an estimated head count of the number of people that would be on the wait list, but I think that would be another very valid data point for you to hear.
Yeah, from our current projections, it's about 278 individuals so far that we have been able to track and project needing services.
And the impact is not just a parent maybe having to leave their job, but the impact is on the individual too. What happens to them, right? They have to be put in an emergency room or some other
Right.
care. So.
Did you have a comment, Ms. Santinella? It looked like you wanted to say something.
No, I was just answering the question that Melissa did, and that's over the biennium.
Okay, Representative Stringham and then Representative Weiler.
I'd just like to ask a question. I think I recall that when people had a reevaluation of what services they were eligible for, sometimes their budget essentially increased because of the change in circumstances. And up until maybe 2021, they only had their own budget available. And part of the one of the changes that was made through legislation was that if there was extra any money in the DD program that was available and somebody had a change in their budget, essentially, that those funds could be used and put into their individual budget rather than having to wait 2 years. And so before that happened, those people were technically put on the wait list again for their new services until an appropriation could be named with the next budget cycle. I guess the question I have is, how significant is the resources for that? Is my memory correct on that? And
Yes, your memory is correct on that. The House bill, though, used our carry forward dollars to fund those increases in budget. So since our carry forward dollars are now depleted with the governor's budget, those dollars are essentially not available to increase those budgets.
so that would mean that people with change in budget now, with changes made even before we consider this, now will have to wait till the next budget cycle to be able to access those new services that they've now been determined they're eligible for?
Yes. So if they needed an increase in their services because we were using that House bill and the carry forward dollars, they would then be put on a wait list for an enhancement to their service. So depending on their budget utilization on an individual level, there might be flexibility there, but those funds in that House bill were part of the carry forward.
Representative Weiler.
I think you can safely assure the people who are fearful of their child aging out of an education program and going on to this program, that these people are well aware of that population and are usually prepared for it. That's been the experience in the past. Thank you.
Yes, sir.
I think the response to that is with this amendment going into place, that security net is no longer there. It's gone.
Representative Seaworth and then Representative Tulerski, if you have a question.
Thank you, Mr. Chairman. I was a little confused by that last exchange, and I'd like to clear it up. I thought I heard, so if someone were to go on a wait list at the beginning of the new biennium, are they necessarily on that wait list until the biennium ends and a new budget cycle? Or is the wait list variable with any number of factors?
So we currently don't have a wait list. So we would have to, with if this does go through and it does change, we would have to develop what that looks like in New Hampshire again if we were to have wait list for budgets. So as of right now, we don't have that concern. So if somebody needs an enhancement, we were able to use through legislation passed, I think it was House Bill 642, to use our carry forward dollars to fund additional services.
Thank you, and I certainly understood that part. What I thought I heard is if a wait list now develops in the future, that wait list would be you would be on that wait list for a minimum of 2 years.
Maximum.
I think that would.
It's at least until the next budget cycle
Right,
when
that
new
would be a
budgeting
maximum
takes
of
place.
2 years.
And am I correct in that once you go on the wait list, it is for the duration of the biennium? Is that correct?
Chris Santinello again. Not necessarily, because as I'm dating myself here, I've been around this for a long time. Before we eliminated the wait list, people were on the wait list. It could have been 2 years, 3 years, 4 years, 5 years, because as Melissa indicated, The current budget accounts for people who are receiving existing services. Anybody that comes in new, we would have to prioritize based on their needs, the numbers, a myriad of items. Depending on where we land at the end of the next biennium would indicate, if more dollars were given for wait lists, then maybe they would come off. If money wasn't given, they wouldn't be able to come off. We wouldn't have carry forward because that wouldn't exist anymore.
Mr. White.
I just want to point out one unique feature that relates to these accounts. So in the current biennium, and it's also included in the governor's recommended budget, there are organization notes tied to each of the class lines, the service class lines, that do indicate that in the event funds are insufficient, the department can come back through fiscal and GNC and receive approval if general funds are available to fund these services. That's a very unique feature. There's only a couple of places in state government where that exists. But I do just kind of want to call that out for purposes of this conversation.
So the bottom line is we have additional flexibility here that we don't have in other parts of the budget.
In 99% of the parts of the budget, you do not have this flexibility.
Right. And I just want to point out that this is a suspension for this biennium only. Representative Tulerski.
Thank you. This goes back to a question I had maybe an hour ago, which was understanding the impact of this wait list and the Medicaid rates, and how they compound and if they compound. And since Mr. Walker has a child and works with families who have, I assume, direct service providers and have this kind of community care, I guess I want to understand what that impact would be if perhaps they would have to reduce hourly wages, if there was a workforce impact, or how that would all cycle through. In thinking about the families that have students that are aging into the system and how they can prepare and understand what's coming.
So I can answer from a couple examples. I have a family that I know of that their direct support professional resigned without very much notice. Okay, the impact on the family, and it was due to wages. It was due to the pay. And the impact on the family was, and this is what you have to understand, is you have a person that requires 24/7 care, all right, or at least observation and support. If somebody pulls the plug like that, it's not like, what am I going to do? I have a month to figure this out. What goes into motion is, what do I do for the next hour? What do I do for the next 2 hours? How am I going to make it through the night? What's the next week going to bring? All right. So that's the kind of impact that happens when you lose somebody. And this Medicaid 3% rates cut, if it translates into reduced wages for direct support professionals, we're going to see more people leaving. Our DSP, she works second and a third job, all right, to make ends meet. And if her wages get cut, I would support her. I would miss her and cry my head off that it happened, but I would support her need to live, and she might have to leave us. And what would that mean for me? I would have to leave my part-time jobs, okay, to be a primary care provider for
I'm going to
myself.
have to wrap this up.
Okay.
I think we have your point, and I have to keep moving because I need to get us out of this building by 6 o'clock, and we're not done.
I thank you for the time.
I
All right.
appreciate the time to ask the question. I'm just trying to understand the multi-layered impact on the community, and it is highly concerning. Thanks.
You're welcome. Okay, so we're going to talk about something totally different now. There are, in searches of new money, additional money, we have some real estate proposals. Line 54, it can be found in Amendment 1420. There's something called the Terrell House that's in Manchester. The initial, and the idea is that we would sell it and that we would use the money from it, and that that money could be used. This would be a reasonably quick sale, so that we could budget the receipts of that money after expenses, obviously, into the DHHS general funds. The initial estimate of this was $700,000. I then started talking to Mr. Arlinghouse about this, and the first call I had with him, he said it's probably more like 400, 450. And then the next call I had with him, he said that he did some more research and it had some asbestos and some lead, so it's probably less than 450. So we could turn it into a museum of historically bad interior design with lead and asbestos. We could do that, or we could just account that somebody would have to clean it up and that the value of this building would be less. So I don't know that Mr. Ripple has been able to keep up with this, but I think I would be comfortable selling this and taking the $300,000. It would maybe be more than that, but book in anticipation of a sale, $300,000 in the next fiscal year. Yes, ma'am.
I just wondered if we're still using it for anything.
I understand that the building is excess in their inventory. Is that correct, Mr. White? That you don't really have a requirement for it?
So the building is currently leased to the city of Manchester. It's a zero cost lease, and that lease runs through June, or that agreement runs through June 30th of 2025.
Do we know what they're using it for?
It's currently being used as a homeless shelter.
So I just dating myself here. I knew Alice Terrell, who left that property to the state. At the time, I think she wanted to use it for people recovering from alcoholism, and probably she's probably looking down on us right now with a broken heart. So
I have a question.
Go ahead.
I don't know if there's anyone here who could speak from the perspective of the city of Manchester and what this could potentially have on those services that are provided. I was afraid so. Okay.
All right. So again, this is a search for money because everyone can spend it. Somebody has to find it. So this is an attempt to find some money. I would, did you pass, is this amendment out?
You should all have that in the back of your packet. And we are carrying $300,000 associated with it on line 47 of your budget sheet.
Yeah, for some reason, I'm not seeing it in my staple packet.
It's one page behind what we do.
Okay.
Mr. Chairman?
Wait a second. Give my eyes a second. I'm not, in the amendment, I don't see a 300,000. Am I blind or is it?
No, the amendment doesn't specify a figure,
Okay.
but we are carrying 300,000 on the budget sheet.
Got it. Representative Nelavenko.
I assume that if we offered it for sale, we would offer it to the city of Manchester as a first.
This amendment doesn't tell DA.
I know, but I'm just
Where's this?
suggesting.
If neither the
that-
city nor county accept the offer.
It would be offered
does
for.
say exactly that.
Yes.
Yeah, it's not just to the city, but it's to the city or county.
Right. Yeah, okay. I think that might satisfy some of the concerns that
Right.
Representative Wallner spoke to.
Well, not all of them, because
Well,
they're
not all of them.
emotional, sentimental, knowing the people. Yeah. All right, so I'd like to make a motion that we accept 1420. Is it seconded?
Second.
Okay.
I just have a
think we can try a show of hands on this. If you're in favor, raise your hand.
There's a discussion.
If you're opposed, raise your hand. So that's 9-1. All right. So now we're on 1421. We're on to Philbrook. Philbrook has had a storied past in the last 8 years since I've been here, so it's probably goes back longer. But because it's on the campus it's on that campus, there would have to be some rezoning, and then it would have to be offered up for sale. The number that I first saw on that was 5 million. What I'd like to do is anticipate 5 million and have that 5 million in the second year of the budget. So that would be finding 5 million for a real estate asset that seems to have not had a real purpose in many years. Are there any questions, Representative Wallner?
But aren't we using that now?
I don't know what it's being used for.
I thought that was I think it was the PACE program. Am I remembering correctly?
Sometimes work expands to fill the vacuum. And so the real issue is if Philbrook is being used for something that couldn't be moved. Go ahead.
Good afternoon. Katya Fox, Director of the Division for Behavioral Health. You may recall that the Philbrook Center was used and stood up as transitional housing during the pandemic with the increased need and the New Hampshire hospital situation where we needed to get people out of New Hampshire hospital and we needed more transitional housing. So through the work of the department, we ran transitional housing at Philbrook. Since that time, we have contracted with NFI North, which uses that facility for the 16 beds for transitional housing. Should that no longer be available, the cost for us to continue those transitional housing services for those 16 individuals will increase as a result.
What's the underlying assumption on why the cost would increase?
Because of the agreement that we have with NFI North for the use of the property.
Questions? Representative Tversky?
So that existing contract line with NFI North is somewhere else in the budget? And how would that impact?
I believe you'll find that in the line item that you're going to be addressing, which is on hold, which is that account 4117 with the $18.9 million reduction. I believe that's where that's funded.
How long is our agreement with the vendor?
I'll need to check on that.
The existing agreement is through June 30th, 2025.
Okay, so it's expiring.
We're in the process of renewing that contract.
How long would you renew it?
Typically, I think we're exercising a renewal option, so it would typically be 2 years, but we can double check that.
I saw Mr. White shake his head.
So we have the option to renew for up to 2 years.
Okay. Up to, so you could pick a smaller time, but the status quo is to do 2 years.
Yes, the general standard is 2 years.
Right. Okay.
Can I just?
All right. Question? Who has a question?
I do.
Representative Wallner.
So isn't this the program? It seems like a couple of years ago you appeared before us telling us we were looking for ways of reducing the number of people actually at New Hampshire Hospital so that we sort of, some people refer to it front door, back door kind of thing. So letting people who didn't need to be at the hospital have some place to go that was appropriate. And then it opened up spaces at the hospital for people who needed that level of care.
So that is the work that you've invested in, the state, the governor, the legislature have invested in that we talked about. I believe it was either earlier this week or last week. And so transitional housing is a significant part of our strategy to alleviate the ED boarding by having the throughput, as I believe CEO Ellen Lapointe talked about. So yes, that's what this is part of that strategy of having people be able to transition to lower levels of care and still get the help they need.
Representative Weiler?
How long does the average person stay there?
Oh, length of stay. So it varies based on the transitional housing situations that we have. I believe that is relatively short term, but I don't have that with me right now.
Thank you.
And you said you could house up to 16. What's the standard census?
It typically is running at that level. You know, there's obviously movement in and out, but it's typically full.
Typically full. And then, as I recall that building, it feels to me like you could have more than 16 beds if you had staff.
So, yes, but it would then tip over into what is considered an institute for mental disease, which then means that the federal government will not pay for any of the services for from a Medicaid perspective. So 16 beds and less is considered to be below that threshold, and so we do get Medicaid participation.
I don't know how you keep up with all these rules. Representative Seaworth?
Thank you, Mr. Chairman. Is there any kind of a rough guess as to how much additional it would cost us if we paid for those 16 beds but didn't provide the building to do so?
I believe that I would need to get that and bring that back to you, and I know that's not possible within the timeframes that we have. As you can imagine, housing is extremely difficult, and one of the reasons why you saw the authorized adjusted 24 numbers being lower, and now I was telling you that we're going to fully expend the amount appropriated, is because of that delay in the location of, in finding a location and a facility that can be renovated or can accommodate these beds.
Okay, so we're going to recess and come back to this one also. Thank you.
Can I just ask you a question, Mr. Chairman?
Sure.
Since you dug into this issue, you mentioned at the very beginning there would need to be a change in permitting or zoning or something.
Yes.
So I don't know the layout of what we're talking about here, where it is, that kind of thing. Near New Hampshire
Are you at all
Hospital?
familiar with the campus?
Of New Hampshire Hospital?
Yeah, we're New Hampshire.
I've been there.
Okay.
Yep.
So, you got a big square, right? So Philbrook is the bottom left-hand corner of that big square, and it's to the left of New Hampshire Hospital.
Okay, so my question to you then is that that's a lot of government buildings there. Is there even potentially going to be a buyer for that space, the physical building itself, and could it be used for anything?
I don't know, but
Okay.
because of the location on the property,
It could be carved out.
It's easy to be rezoned. So
That-
rezoning's never easy, but the lines are there to rezone.
You answered my question a little bit. It's on the exterior part of the property that it could be cut out, but
Yes.
okay, I still question if
Sure.
there would be an attractive buyer attracted to that, but thank you for that
You
clarification.
bet. Right. Yes. Okay, so the next item, so if we did the Philbrook, I don't think we could book any revenue from that until 27, the second year. So it's not a first year solution. Then there's one that just says TBD, because I think it's still being drafted. And basically what this would do is would take the Hamstead campus, which is a really big, if you've never been, it's a really big, nice, beautiful piece of land in Hamstead. And all around the campuses are these beautiful homes, extremely expensive, beautiful homes. And what the determination would be is we don't need all of that land to fulfill our state function. And so we could either find a developer that would want to develop on that land some big, beautiful $1 million homes, or we could offer it to Hamstead to see if they might consider working with us to turn it into a preserve. If the second option was preferable, then that would be $1 million that we could book, but not until the next budget year. It doesn't help us this year because the whole process of talking to Hamstead and working it with them and finding out if they're interested and all the like, that's just a very long government process, a socialization process. But that is one of the House bills, and I think the House bill is 1435. It just got handed out, and I've not read this, but what I'm hoping is that this is written in the tone that the department will work with the city of Hamstead to determine what might be a mutually acceptable way of using unused property at that campus. So we wouldn't book anything, but we would ask that the department begin deeper negotiations and assessment with the city of Hamstead. That's what this is. I'm going to hold this also for after we recess because I think you just had an opportunity to read it and you may want a little bit more. Okay, so you think those were the crazy real estate ones. The other crazy real estate one was the Sununu Center. It's already on, in law that we're going to sell it when we get the kids out of the existing facility and into the new. And at the rate we're going, the availability of selling it probably isn't into the next budget anyways. It could be an $80 million property though. There's a great deal of potential, but it's just too big a deal, and there's already legislation to put a sale into an HB2. So just to be thorough, I had the AG, the department, and DAS and the Treasury Department, the four of them talking to each other to see if it was possible for us to basically take out the equivalent of a home equity loan against it. Basically say, this is a valuable piece of property, we have equity in it, we'd like to be able to borrow the equity out. I was hoping if we could borrow that equity, then that money could be used to pay for the Sununu Center in this next budget, or maybe a reserve for the settlement money, but to try to get some cash out of that very valuable asset. So a lot of hard work went into that, and the conclusion came back is I got credit for a crazy idea, but because the property has some bonding issues, it's not, we couldn't also put it into a loan status. So that's just off the table, but I wanted to share that story with you because I want to spend more money. And in order to spend more money, I need to find more money, and I'm having trouble doing that, and we're trying to do that. So, I think I'm ready to have us, and while we're in recess, Mr. Ripple, would you take a look, please, at this other sheet that you put together for us? Because I don't want to leave here and accidentally leave something loose, okay?
Right, yes, I will.
I think we've hit the long sheet front and back, and we probably incidentally hit a few of these guys in the way, but I don't want to miss anything.
Okay, I will.
Okay, so when we come back out of recess, we'll vote on these last HB2 items, and then we'll make sure that we haven't forgotten something. And at the conclusion of that, Division 3 recommendations will be ready for full finance, and we can all go home and have a really miserable weekend. So with that, I'm going to put us into recess. It's now 4:37. I'm going to say we come back at 4:50. All right, it took longer than I thought. It's 5:10. We're coming out of recess. I really think we have to be out of here by about 10 minutes to 6. I think our caucus has our positions understood. I think we've done a lot of discussion and debate. So I don't know that we need to spend much more time rehashing. A new item that we haven't yet talked about was item 1. This is on the landscape document. This is reflects full funding the department community mental health programs at the highest they've ever spent, which is 31 million, which is a reduction of about 18.6 million per year, almost 19 the second year, excuse me, in general funds. But that keeps them at the highest spend to date. We may have talked about that Monday or Tuesday briefly, so we have talked about it. I would take a motion on line item 1.
I would move to approve line item 1.
All right, is there a second?
Second.
Second. So it's moved. If you're in favor of accepting line item 1 with the attendant reductions from the governor's budget of 18.9.
Brief comment?
Brief comment.
Yeah, brief comment. Just wanted to remind everybody that part of our discussion was the expenditures on that program this year is on pace and expected to be 42 million. Thank you.
That's fair. All right. So all those in favor of accepting the motion, raise your hand. Okay. I see 6 opposed. I see 4. So that passes 6-4. Okay, on the next page, here's a little bit of good news. If you take line item 20 and you also go look at line item 39, what happened was the department wanted to make sure that we funded the DocuSign. So they were tasked to go away and try to figure out what kind of savings could be done, because that's meant to be an efficiency measure. So the savings that they think they could find and they're willing to put into the budget are reflected on line 39. So if you take a look at 20 and 39 in combination, basically this, finds an additional 134K that we didn't have when this process started. So I would take those two as one motion, line item 20 and 39, and I would move that we pass those two items. Is there a second?
Second.
Okay. It's motion. Any discussion, comments? Okay, so my comment is nice job, Mr. White. You delivered, thank you. So if you're in favor of accepting in combination line item 20 and 39, raise your hand. None opposed, so that's 10-0. On line item 28, the document I'm looking at says removed, but we've since clarified that and voted earlier that we're suspending the WIC program. So I'm just only commenting on it because this document says it's on hold, and I want you to know that we already voted on that. We accepted the proposal. Line item 27. This is a reduction in a contract for epidemiology services, and I'm told there is no federal funds impact, and that any testing for PFAS and Merrimack is still possible in there. So this is a reduction of 18.2 in each of the 2 years. Representative Priest.
Yes, thank you for acknowledging me. Which line is this again?
27.
27.
I'm talking about 27.
Okay, thank you.
Yeah. So all those in favor of accepting line item 27? Oh, did we do a motion? I thought I,
I'll move approval of line 27.
second? Okay, thank you. So, all those in favor, raise your hand. So that's 7, right? All those opposed? That's 3, 7, 3. Thank you. Okay, so line 33, the Stringham line. So I'm proposing, because we're finding some reductions here, we still got a big back of the budget. It's getting close to 50 million. But still, I think your point has been well made, and rather than doing the 2 million that you mentioned over the 2 years, I'm proposing that we split 500 million between the 2 years to 500,000, excuse me, not a trillion? Okay, 500,000 between the 2 years to give them something and to make sure the Senate sees it.
Thank you for doing that.
Thank you for your analysis. I wouldn't have caught it the way you did, so I appreciate that. So if I need a motion on line 33. You move?
I move.
I'll second it.
Okay. So all those in favor of line 33, raise your hand. Okay, that's 10-0. The Stringham amendment goes through. Okay, so for those of you who have been looking at this line 38, it came into us at $256,000 a year. It came into us reading that this was a Safe Stations program. Well, the Safe Stations program went away years ago. The budget line item didn't get updated. The city of Manchester received the money in any case, and they've been funding something called Rescue One, which is an important capability for them and a very busy capability. And so I've had a chance to talk to the mayor and about 3 of his fire department people and one of our reps from Manchester. And I think I know that instead of the 256, they can work with the 192 each year. So that saves us $64,000 each year. So that's a $128,000 savings on that line. So can I have a motion on 38?
I was just going to say, I'm going to vote against it just because it came in so late and I can't double check everything.
Right.
But your logic sounds pretty good.
Right. Right. And the people who bought into it is what I'm relying on. It was kind of a negotiated settlement. So, all right. So is there,
Mr. Chairman, I move approval of line 38.
okay. Is there a second?
I'll second.
Second. Okay. If you're in favor of line 38, you'll raise your hand. Okay. If you're opposed, you'll raise your hand. So that's 6-4. So 39 we did. Okay, 40 is not a new topic. It just seems like we've been talking about this every budget cycle. Number 40 proposes to eliminate the Choose Love program. That's about $500,000 between the 2 years. Is there a motion?
I move we adopt this line.
In a second?
Second.
Second. Okay, any discussion? We didn't talk a lot about this year, but we talked about a lot last year. So all those in, do you have a question?
I just wanted to reiterate for the members who weren't here, we've talked a lot about this, and about how this came about after the Sandy Hook shooting. It was something that the previous governor was really impassioned about and supported it strongly. And I will not be voting for this, as I feel it does contribute to some social emotional education that happens. But thank you.
You're welcome. Okay, so all those in favor, is there a proper motion? We heard first and second. Okay, so if you're in favor of line 40, you'll raise your hand. Okay, so that's 6. Those opposed? 4, 6, 4. Okay, Project Walk is something that we haven't really talked about. It spends about $250,000 a year. It's been on this list, but I don't know how long everyone's had a chance to see this list. But we're looking for money to put into things elsewhere. So I recommend that we accept line item 41.
I have a question.
Question?
So this is the first time I saw this was yesterday, late day when we were in session, an email. When I scanned this, I've never heard of Project Walk, and have not had the time to dig in. I don't know if anyone can give me a high level view of what it is before I decide that it's worth cutting.
I don't know that I'm really great at giving you a high level view of the Project Walk. One of my friends does it, and when I mentioned to my friend that we might cut this, there was some consternation and a shrug that we're running out of money. Is anyone here in the department able to talk about Project Walk?
Hi, yes, I can speak a little bit to it. It is a outpatient rehab facility for people with physical disabilities, but it's a recreational based program. So I believe the funding was allocated the last year. So I don't know much more. I don't know how many people they serve, but it's and I think it's in Stratum as an outpatient kind of recreational physical therapy program.
Right. So is it physical therapy that's related to a medical order, or is it just happened to have a secondary, because it's recreational, secondary impact on physical therapy?
I would say the latter of what you said. So certainly people have a physical disability. And
exercise is good.
Yeah.
Yeah.
Can I just ask a quick question?
Absolutely.
Does this affect children or adults?
I'm not sure. Definitely adults. I don't know if they serve children. I don't know.
Any other questions? Representative Stringham, your mic is on. Oh, excuse me. Seaworth, your mic is on.
And I was going to say that if you didn't get it, I didn't hear a second for your motion, and I would second it.
Okay. Thank you. All right. All those in favor, raise your hand. Opposed? 6-4. Okay, now 42 has no financial impact. Something the Division 2 was doing was taking educational trust fund money and swapping it with general funds, and because DHHS had some, I think, general funds that we want to swap, this line lets us do that swap.
Yes.
It's a technical fix.
It is a technical fix. As a result of the actions taken in Division 2, there would no longer be statutory authority to draw from the Education Trust Fund for this purpose. So I would ask you to vote to move $3 million per year from the ETF in account 2958 to general funds. But because Division 2 has also allocated the same amount of ETF revenue to general fund revenue, there'll be no fiscal impact.
Right. So I think this is just our companion technical fix to follow the Division 2 decision. is my take. Go ahead, question?
Sort of a two-parter. How does this affect the DHHS line items?
Do you want to go into detail?
Well, I'm not in the best position to describe what's funded out of that line item, but I will tell you it will be fully funded. It's funded in the governor's budget at $3 million per year, and it will be funded at the same level as a result of this action. It would just be general funds instead of education trust funds.
And a follow-up, I know
Yeah.
Chairman Weiler was probably in there if he could explain.
Representative Weiler?
So what we had was the Education Trust Fund at its inception was just to pay for adequacy. The previous budget, the governor put in 35% of business taxes going to the Education Trust Fund. I said, that's too much. We changed it to 22%. We sent it over to the Senate. They made it 41%, which resulted in Education Trust Fund in the second year having a surplus of 129 million, which we couldn't use anywhere else. And there were a lot of places we wanted to spend that money, but because it was in the Education Trust Fund, we couldn't move it. So I said, let's go back to doing something around 20% of the business taxes and all the other sources of taxes. So they put numbers on them like 70-30, 70-30 to make sure that they didn't overfund Education Trust Fund, because all the other years, all we ever used the Education Trust Fund was for adequacy, building aid, special ed, tuition, transportation, et cetera. All those things came out of general fund, special ed and all that stuff. And so there's no need to put all that money in the Education Trust Fund. So they're doing what we did previous budget and reducing the amount of other taxes that go into the Education Trust Fund. And so this freed up $3 million that obviously is no longer going into the Education Trust Fund, so it's available to the other parts of the budget.
Can I just ask a clarifying question? Is then from, if it's just affecting $3 million, this is not what last biennium, with all respect, we called the Weiler Amendment?
Yes.
Or it is the Weiler Amendment to take the surplus from the Education Trust Fund and move it to the general fund?
It's a subset of
It is
that.
the Weiler Amendment.
A subset of it. Okay, I guess
Right, 'cause
I'm
it's
having a
on-
hard time.
Because it's only 3 million.
That's what I'm having a hard time with.
Yeah.
We're talking about 3 million, but from what I understood of the Weiler Amendment last year, it would take
More.
much more money.
Right. I
Now,
think your memory
I
is
think
right.
they've settled at 30%.
Yeah.
Last, the Weiler Amendment was 22%.
So to keep it focused
That's
on
fine.
Division
That's fine. I
3,
just wanted to understand.
Yeah.
But I understand this is for a technical fix that I don't understand.
Right.
So thank you for the time.
Yes, ma'am. So 42, I'd like somebody to move 42.
Move approval of line 42.
Second.
Second.
Second by Weiler. If you're in favor, you'll raise your hand. If you're opposed, 6-4. The next one has a couple accounting areas. Both of those two accounts are driven by the same premise that residential placements can be reduced 10% in the coming budget. That's often an often stated goal of the advocates. And in this case, the department, when we achieve that, will save over $5 million each year. So this is new money to reduce the back of the budget or to be reallocated to other priorities. Well, that's why I mentioned there's two line items. There's the 2 million and the 3 million. You got to take the two collectively. Okay, so does somebody want to move 43?
Move approval of line 43 and 44.
Not 44 yet.
Not 44 yet?
No, 43
Okay,
has
just
two
43.
sub-accounts. So just 43 at this point.
So moved.
Just 43, second.
All right, if you're in favor, you'll raise your hand. If you're opposed, 6-4. Item 44, reduce developmental services waitlist funding. Okay, so earlier on 44, there, an HB2 item was discussed that would have suspended the DD wait list for the biennium. And so we'll need to amend that for this proposal, which is to eliminate the suspension, but from the governor's budget, reduce the budgeted amount by those shown in the general funds in 26 and 27.
So I think you could do that by adopting line 44 and not adopting the House Bill 2 amendment.
Right, so we can just withdraw the HB2 because the authority to do this is already all in HB1 and supported also by an organizational footnote.
Yes, there's a footnote, as Nathan pointed out, in account 7100 that allows the department to go to fiscal committee in the event that the expenditures are greater than the amounts appropriated. So there is an escape hatch of sorts to prevent a wait list.
All right. Yes.
I just want to
question,
clarify
please.
it for the
No.
public and people who are listening. So if I understand correctly, the HB2 item, which suspends the requirement to not have a wait list, that will not be acted on.
We'll pull it.
But we're still going to cut the line item
I'd
to
like to say recalibrate, but
recalibrate HB1 to reflect that we actually did that,
yes.
to reflect the savings. However, the department would still be mandated to fulfill all of the needs for the wait list, or no wait list,
There's no suspension, there's no waiver from the existing law.
but just reducing the expenses. Yeah,
Yeah.
the DD, yeah, because it's not a wait list.
A lot of this is based on estimates.
Yeah, and hope and a prayer.
And then they have a fiscal committee out if they need it.
Yep. Okay, I just want to be able to understand it. Thank you.
All right. I think I described that accurately. If I didn't describe that accurately, tackle me.
No, I believe you did.
Okay. All right. So line item 44 is actually two things. One, it's the withdrawal of the HB2 that had the DD waitlist suspension, which is 1419, and the maintenance of the HB1 item of reducing the governor's budget on the appropriate line to subtract 8.877 million in year one and 22.499, I think, my eyes are blurry, in year two. So that I just kind of made the motion. Does anyone second that? Second. If you're in favor of those two things in combination, you'll raise your hand. If you're opposed, so 6-4. So Will, that at least takes the suspension fear out of the public. Thank you for your testimony. Okay, 45. I'm going to propose that we accept 45 with the 3% cut and recalibration, excuse me. And this reduces the back of the budget cut that would have to be made. And it's such an enormous thing with so many constituents that this will surely have an opportunity to be heard in the Senate. And I am hoping the tradition pays off in that they end up having more funds available than we do. So I don't like doing this. I think anytime the government reneges on a commitment and budgets have been done, this is the last thing you want to do. It's a horrible thing to do, but but I think in this case, we need to do it and put a big flag on it for Senate review. So I will move line item 45. Is there a second? Second. Okay. If you're in favor of line item 45, you'll raise your hand. If you're opposed, you'll raise your hand. So that's 6-4. Okay, which takes us down to line 46. Delay the June 2027 MCO payment until the start of 28, and that basically right shifts 25 million from the last month of the next budget to the first month of the budget in the future.
Didn't we already vote on this?
Did we? Yes. Oh, good. I just, good. Thank you. All right. So a new idea. Did we vote on selling the Terrell house? I think we did. We voted to do that and that we're booking 30,000 for that. Okay. And then, the Philbrook Center, I don't think we voted on, because we wanted to talk about that. And Ms. Fox, as always, had a compelling argument, and I don't mean to demean the argument, but I need the $5 million. So this was supposed to come in at 7 million, and I think we should only count on 5 in the budget, and it wouldn't be available until the second year, because it's going to take that long to work through the rezoning and the sale and everything. So why can't I find that sheet where it has?
Well, it is item 48, and it has 5 million on it.
It does. Somewhere it had 7 million. The first estimate I was given was 7 million, and then I basically made a wag to reduce it to 5 million to be more reasonable. So.
Well, the only thing I have says 5 million. So.
Yeah. Okay. So you weren't privy to my inner brain of 7 million. So, is there an HB2 item for that? There is. And you handed it out.
It's 1421, the last amendment in your packet.
Did we, so we're voting on that amendment?
Yes.
Okay. Somebody want to move that amendment?
I will move the amendment 1421.
Is there a second? Second. All those in favor, raise your hand. Opposed? 6-4. 49 is a new item, the impact of which does not affect the coming budget, but nevertheless, we need to put the canoe in the water and have somebody start paddling so it's available next budget. This is a proposal. I don't have the amendment number in front of me, but there's an amendment that basically has us.
We didn't have an amendment.
1435.
Is there one now?
For Hamstead, you have amendment 1435.
Okay, so 1435 basically has the department beginning to have conversations with Hamstead on what to do with an oversized lot. Would somebody move 1435?
So moved.
Is there a second? Okay, if you're in favor, you'll raise your hand. Okay, opposed, no one, so that's a 10-0. Okay, and we talked about the Sununu Center, and there's absolutely no action there to vote on. I think the last item is you've been working furiously while you haven't had anything else to do on an HB2 to reflect the back of the budget. What do you got for us?
Yes, I have, and I'm sorry to ask you to take another vote. So you voted on the status of budget actions sheet on the savings from the Medicaid 3% reduction. You did not technically vote on the House Bill 2 amendment, which is 1422H. So I guess it's up to you if you consider your previous vote a vote on this amendment, or if you'd like to take a separate vote.
I think we can take a separate vote just to make sure that your record is clear. So I move acceptance of amendment 1482.
22.
22.
Where is it on the tall sheet? Oh, I found it. Okay.
Second.
Okay. If you're in favor, you'll raise your hand. So that's 6. If you're opposed, 6-4. So there's a vote now. So now is it true?
Before you move on, can I ask one little question? Sorry. We had a conversation earlier today about a topic that you said we would maybe come back to, and I'm just wondering if you would be open to reconsideration of that vote for the family planning line.
I think we might need a vote on reconsideration. Do you want to make a motion to reconsider?
Sure. I'd like to make a motion to reconsider line 17 on the HB1 list, which had deleted the family planning account.
Is there a
And I
sec-
will second that.
There's a second? Okay. Is there any further discussion? So if you're in favor of that motion, you'll raise your hand. If you're opposed, you'll raise your hand. Okay, so that loses 4-6.
Thank you for allowing us to vote. I appreciate it.
You're very welcome. It's actually absolutely the least I could do. And I wish I could do more. So, okay, so I was ready to turn the stage over to you for.
So I have a draft amendment to hand out now. If the committee adopts this, we'll have it formally drafted by OLS. This would be a back of the budget reduction, requiring the department to reduce general funds of $23 million in fiscal 26 and $23 million in fiscal 27.
Did I miss anything? Okay, so I'll take a few minutes just. So Mr. Ripple, when you get back to your seat, when you get back to your seat, my question for you will be, what method did you use to derive the 23 million a year? And are we expecting the potential for change?
I am not expecting a change. The 23 million a year was intended to, in combination with all the other actions you've taken today and on Tuesday, to get Division 3 towards its biennial reduction target of $290 million. And that target was contingent upon the actions taken in Division 2 today. Those votes went as we had assumed, and so that $290 million target is still firm.
Okay, so a 46 million back of the budget is still a big back of the budget, particularly with the cuts that we've taken. And I think I don't think we have an alternative at this point. I think we've tried to be as exhaustive as we could, as collegial and collaborative as possible. That's included work with the department, with the governor's office, with various departments in the state government. And I apologize. This is absolutely the best I think I could have done. And everybody's work is integrated in this as best I could move us. And so with that, I would like to make a motion that we accept this draft back of the budget for Mr. Ripple to have turned into an official document with the terms stated in here. It should be identical to this. And the next time we get together, we'll be in front of a full finance committee, and we can all see the amendment at that point. You may be able to email it to us, right? So,
Yes.
so we'll, if for some reason there's a problem between now and the final version, we'll have an opportunity to catch it and correct it. So that's a very long motion. I move that we accept this draft HB2 amendment for a back of the budget cut of 46 million.
Second.
So there's a first and a second. If you agree with that motion, please raise your hand. If you oppose, okay, so that's 6-4. Mr. Ripple, I think we've done everything.
I think you have as well.
Okay,
Could I ask a question?
Representative Wallner.
As you're preparing the documents that we'll use, I hope that we will be able to show the federal funds, which, I mean, they are shown in some areas, but not all areas, so that the document, people will have a clearer view of what the real cost is here.
The federal fund reductions in the case of the Medicaid rate decrease and the delay of the MCO payment will not be shown. So the type of document that we generally prepare for the full committee presentation is what we call a detailed change sheet, and that includes the House Bill 1 items. That reduction was not taken as a House Bill 1 reduction. It's a direction to the department in House Bill 2 to reduce appropriations related to those actions. So the federal funds won't be shown on that detailed change sheet. I will make a note on the side of that sheet indicating the amount of the general fund reductions and that federal fund reductions will be made accordingly.
Will there be an amount as to how much, when you have the note next to the line, will you note how much federal funds will be lost?
I think at this point, I don't have the detail necessary to do that because it's standard Medicaid is 1-for-1, but there are also reductions to CHIP and Granted Advantage, which come with different federal matches.
Okay, thank you. I think it's a shame that we're not going to be able to really have a full picture for people.
Have we ever had a full picture at this point of the impact on federal funds? I ask that honestly without knowing the answer.
When done in House Bill 2, no, generally you haven't. So for example, there was a rate increase, 2 rate increases of 3.1% done back in 2020, and we only showed the general fund impact.
Okay. Yes, Representative Priest.
Yes, I agree with Representative Wallner, but I would like to expand that even more so for future budget considerations. And that would be to show the number of people that will be directly impacted by these actions. The thousands of people that are in poverty and that cannot afford these services, who will be having to go without. And I think that should also be shown, so the decision makers can see that there are actual people behind those numbers. Thank you.
Are there any other comments from the members? I'm not going to ask for last call from the gallery because I don't know what horrible things you might be thinking. So I won't do that. I hope you feel like you've had a chance throughout the course of the day to say whatever you needed to say. And I'm sorry if you didn't hear what you wanted to hear today, but it's on to the House and then hopefully on to the Senate. And so the process continues. It's not over. This is a way station along the way. So with that, I will close today's hearing. It's 8:48 and we're supposed to be out of the building by 6.